Somatosensation. My batteries are dead, so I'll just use these. So we're specifically referring to soma, body, sensation, okay? And we're talking about sensory information from the skin, bones, muscles, ligaments, joints, okay? Sensation is obviously critical to our human experience. It allows us to investigate the world, move accurately, and also avoid and minimize injuries. You know, sensation is a huge part of minimizing injury, and we'll talk about pain and perspectives on pain on Friday. Okay, so we'll go into that more detail. Let's just start. A lot of today is kind of understanding definitions and terminology as we refer to the somatosensory system. We can talk about two very just kind of gross types of pain, or not pain, but sensation, okay? Subdivided into either just superficial sensations that we feel in our body or what we call musculoskeletal or deep sensations, okay? So that's kind of the two general terms we'll use to describe the basic breakdown. So superficial would be things like pain, specifically on the surface of our skin or surface of our body, so kind of pain on the surface. Temperature, typically when you feel temperature, this is a superficial type sensation. And then touch, superficial pressure and vibration, okay? Those are superficial, these are all can be superficial sensations. We can also have pain as a deep sensation. So deep sensation pain usually tends to be that more deep aching type of pain, okay? Where superficial pain tends to be more of this kind of quick, it's there. Usually you remove the pain sensation. Like if you touch a hot stove, you get the initial superficial pain of that hot stove. You remove your hand, you get that initial flash of pain. Then you get this kind of achy pain afterwards, and that tends to be more the deep pain. It's the deeper tissue now that's responding to that painful stimulus. The other thing about deep sensation is what we call proprioception. So it's the ability to tell where our body is in space, our position sense, stretch, tension, position, all those things, these deep sensations are called musculoskeletal sensation. Okay, so we're going to get into some more detail on these as we go through. Here's how sensation travels from the periphery or from one location in our body up to wherever it's going to be processed in the central nervous system. Okay. So on your left-hand side, you have what we call more than just a very generic or general way that we feel sensation. So typically it involves some type of stimulus, stretch, pressure, vibration, hot, cold, pain. Okay, so you get some type of a stimulus. That stimulus activates some type of a receptor. Okay, so we have these receptors in our body. Some can be very specialized, some can be not so specialized. But some type of receptor gets stretched, pushed on, or a chemical falls on it, something that causes the receptor to depolarize and cause an action potential, right? And that's how we start that stimulus. That signal then has to travel up a peripheral nerve, right? Or towards the central nerve, an afferent neuron, okay? It's going towards the central nervous system, okay? So that's on a specific peripheral nerve, okay? Or type of axon that's carried on. It eventually goes into the spinal cord or the brainstem if it's a cranial nerve, and then it goes into the central nervous system. And then that goes up some type of a pathway, okay? So once you're in the central nervous system, this is where we're talking about these sensory pathways. And depending on the type of sensation it is, it's going to go to a final destination. That final destination could be just end in your spinal cord. It could go to your brainstem, or it could go to your cerebrum. If you're going to get conscious awareness, or it could go to your cerebellum and stop there. So there's different destinations for the sensory experience, depending on what type of sensation and the purpose of that sensation. So that's kind of general. Here's a specific example. The specific example here is going to be with a pinprick to the arm, which is going to be pain. Okay, so you're going to get some type of a stimulus, and this will be a pinprick to the arm. A pinprick to the arm that causes pain will stimulate a free nerve ending. So when we talk about the type of receptors, one type is a free nerve ending. Okay, that pinprick, stretching, pulling, pushing on that free nerve ending causes it to depolarize, causes some modality-gated sodium channels to open, And enough of those open, and that causes the voltage-gated sodium channels to open. You get the action potential, which is a stimulus of pain because you stimulated this free nerve ending that has a certain threshold that if you exceed, that's called your body's going to perceive it as a pain stimulus. That is going to go up. So depending on where in your arm, it's going to be, it might be on your median nerve or your ulnar nerve or wherever, and it's going to go up into your brachial plexus and into your spinal cord, right? But the axon that's going to travel, that's going to go up on that axon, or several axons if you've stimulated more than one free nerve ending, which you typically do. So it's going to be traveling along an axon, and that axon is classified as a certain type, okay? In this case, it's going to be an A delta fiber, and we'll get into all the different types of axon classifications for sensory neurons, okay? So it's going to be an A delta fiber. It's going to enter into your spinal cord, and it's going to ascend in what's called the anterolateral system, or you may just want to add in there's also spinothalamic tract, okay? So it's going to ascend in the anterolateral system / spinothalamic tract, and eventually it's going to go to the ventral posterior lateral nucleus of the thalamus, the VPL, and then from there it's going to go actually to your postcentral gyrus and your cerebrum for you to have conscious awareness of that pain, to say, I just had a pinprick happen right there. So these are the stops along the way. After it gets into the spinal cord, this is our sensory pathway, and then finally our final destination that it's going to go to. Okay, so that's just one example of that. Okay. So today you're going to get to learn about 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11 different pathways. So some of these you can kind of group together, so you don't have to memorize every detail of all 11. But some of you in your neuro or physiology classes probably learned about 2 pathways. You probably learned about the pain one, the spinothalamic tract, and you might have learned about the proprioceptive tract called the dorsal column medial lemniscal system. Those are the 2 that most people learn something about or have heard. Maybe you get, because you're DPT students and you're so awesomely smart, you get to know all the detail of all these different pathways, breaking right on down. So, okay. So that's what you see here. This is going to give you a little more information about what we're talking about today. So we're going to kind of go in this order today somewhat. So we have our somatosensory system as a whole, and we're going to break it down into the different components. We have the receptors. We have to have some type of receptor out in our periphery that initially is stimulated, that initiates the signal, okay, that gives us the sensory experience. So this just shows you can kind of break that into, there's 3 main types of peripheral receptors, general categories, mechanoreceptors, chemoreceptors, and thermoreceptors, and then you can break it down into further. So you'll see mechanoreceptors are all these guys right here. So mechanoreceptors are these first 1, 2, 3, 4, 5, 6, but then down here is free nerve endings. And free nerve endings are interesting because they can act as a mechanoreceptor, a chemoreceptor, or a thermoreceptor. So they can act as any one of those. Okay? All the rest, though, are typically classified as mechanoreceptors that we're going to talk about. Once you stimulated a receptor, it's got to travel on in a nerve, okay? And that nerve is made up of a bundle of axons typically. And the type of axon, you have these different classifications of axons that are dependent on the diameter of the axon and the amount of myelination it has. So we'll get to that. But these are your primary sensory neuron classifications right here. Going from, this is typically fastest to slowest here. Is kind of a general way I've got these organized here. So we've got 1As, we got 1Bs, we got 2s, we got A betas, we got A deltas, and we got C fibers. Okay, so those are the different types of axon types that pain, proprioception signals can travel on. Okay. Then we have our sensory pathways. Once we get that information from the periphery into our central nervous system, it's going to go up a sensory pathway. We have 3 major classifications of pathways. We have what's called fine, conscious touch, and proprioception. Okay? So this is touch that when somebody touches me right here, I can point to that exact spot, or if I bend my wrist this way or that way, and I ask you which way did I bend your wrist or your finger, you can tell me exactly you bent it up or down, or if I ask you what position your body is in or match a position, you can do that consciously. That's your fine touch conscious proprioception. So in that, we have two main pathways for that. One is the dorsal column medial limbical system. That's conscious proprioception for the body. Then we have an analogous system just for the head and face that tells me where my jaw is in space or where my nose is, and those kind of things. So that's the trigeminal pathway is what it's called, for lack of a better term. It's just called the trigeminal pathway, and that's for the head. Then we have the pathways that are all associated with what's called unconscious proprioception. This is where your body is getting information, or your information is coming from your body, typically from joint receptors, muscle spindles, some peripheral receptors too in the skin, but more so the deep sensation. This is going to your cerebellum. So it's the spinocerebellar. It's going from your spinal cord and stopping at your cerebellum. The spinocerebellar pathways. There's actually 4 of these pathways that bring that information from different regions of your body, from your upper body and lower body to the cerebellum. And those are all collectively called the spinocerebellar pathways or system. Okay? And then lastly, we have what's called coarse touch. Coarse touch is very generic touch, like I can tell you touched my arm, maybe my left arm, but I can't point to exactly where it is. It's just kind of this. It's also sometimes called itch and tickle. So sometimes like I can tell my arm itches, but it's hard to tell exactly where it's itching, and it's just this itch and tickle pathway. But that's the same thing as also that you carry pain on, the pain pathways. So coarse touch / itch and tickle, and then pain and temperature. Okay, pain and temperature. Those are all carried on what's called the anterolateral system. Okay. That can be then further subdivided into what's called fast localized pain. So that's that sharp, initial, discrete pain experience you have that's typically more brief in nature, and you can say exactly where that thing hurt, and you can point right to it. And then that's divided into 2 categories: the spinothalamic tract, which is your body's sensation of fast localized pain, and the trigeminal thalamic tract, which is your fast pain from your head and face. Trigeminal nerve, trigeminal thalamic, okay? And then you have what's called the slow aching or divergent pathways, because once this slow aching pain, that's this like deep aching pain you get that can be like more chronic in nature or it comes on after that initial pain experience, it tends to diverge. It tends to go to several different locations in your neuroaxis, within your nervous system, okay? It doesn't just go up to your cerebral cortex. It goes to your brainstem, the spinal mesencephalic. Remember mesencephalon, mesencephalic? That goes to where? Midbrain, okay? Somewhere in the midbrain it goes there and gets processed. Then you have a spinal limbic. Spinal limbic goes to your limbic system, which is part of your cerebrum, but it's more that emotional connection that you experience pain as it relates to emotional experience. And then you have a spino-reticular pathway. The reticular system is in your brainstem as well, and we'll talk about that. But it goes to different locations, and that deep aching pain, is something that's experienced at multiple levels in your nervous system. So anyway, this is your guide to today, basically. When you want to go back, where are we at, what are we talking about, you can always go back and refer to that. So sensation starts in the periphery and comes more centrally, so that's how we're going to kind of approach this, starting with the peripheral receptors and sensors, and then working our way up into the pathways, okay? So the types of receptors can be grossly divided into either as a mechanoreceptor, a chemoreceptor, or a thermoreceptor. Mechanical, something, you twist it, you stretch it, you poke on it, that's mechanical in nature, okay? Responds to mechanical deformation, touch, pressure, stretch, or vibration, okay? Then we have chemoreceptors. We do have chemoreceptors that respond to substances released by cells or damage nearby. So and chemoreceptors are always free nerve endings. So if you want to put here, it's always a free nerve ending. Mechanoreceptors can be any one of 6 types, which we have listed there. It can be a Pacinian corpuscle, it can be a Meissner corpuscle. It can also be a free nerve ending. A free nerve ending can act as any one of these. So it could be a free nerve ending, it can act as a mechanoreceptor. Then we have thermoreceptors, which respond to hot, cold, changes in temperature. Those are also always free nerve endings. Okay, free nerve endings can act as thermoreceptors. Those types of receptors, depending on how they're stimulated, they can respond, or actually the nature of some of these receptors is they can either be a tonic type of receptor or a phasic type of receptor. So a tonic receptor means that if you stimulate one of these mechanoreceptors, it will respond as long as the stimulus is maintained. It'll keep sending a signal that gives you some sensory experience, and it'll stay on as long as, like, if I push on their skin and hold that position, there's receptors, there's mechanoreceptors that are tonic in nature that I can still feel after 5 minutes that somebody's still pushing on my arm. Okay. There's also phasic receptors, and phasic receptors, you push on it, you get an initial burst, and you get this sensory experience when you first deform the tissue or get that signal started, but then they go silent. And so initially when you sit down quickly on a chair or something like that, right, you get this burst of sensory information that, boom, my butt just hit that chair, my back just hit the chair. You get this burst. Those are from the phasic receptors. But then over time, you can almost forget that what's going on your butt and your back, because especially if you're attending to other things like a lecture or something like that. But if you go back and now think about where the pressure is on your butt and your back, you can still feel that, right? But it's at a little lower level. But those are the tonic receptors that are still firing in the background all the time that are giving you some indication about pressure on your bottom and those kind of things. So those are the tonic receptors. So you have both tonic and phasic receptors. The tonic are more for the baseline, constant information that you need to experience in life, whether you're just sitting there. The phasic are what's happening when you're moving, transitioning, a stimulus is being applied or taken off. They tend to be a little more active in that experience. Okay. I added this slide. Actually, last night I updated the PowerPoint last night. So sometimes I do that. I'll occasionally be working on stuff and I'll update it. So it is updated in Isidore now with a couple extra. I just threw a couple extra pictures, slides in here. So on the left is an example of a slowly adapting, or what we call tonic receptors. Okay, so tonic receptors, you apply a stimulus. Okay, so I push on my arm with a certain amount of force. Okay, so this is the stimulus strength, whatever that, they call that the 0 point. But a stimulus is applied with a certain amount of force. I press down, maybe 20%, I don't know, whatever that is. So here's the stimulus coming on. You see, here's the receptor potential in millivolts. So this is the actual depolarization of the receptor. Okay, initially you see a burst of depolarization that's even a little higher than what we call kind of baseline for that. And then it kind of levels off, but it still stays above normal. So this is your 0 point, and this might be, you know, plus 20 millivolts or something like that. And now, but this is plus 10 millivolts, but it stays depolarized the whole time. So it's giving you constant feedback about that receptor staying stimulated the whole time that you maintain the pressure on your arm. Okay. And then when you release it, then it goes back down to baseline again, okay? But it stayed on the whole time. Where a rapidly adapting receptor or a phasic receptor, what it does is here you apply the stimulus, you get this pretty strong burst of activity right away, but then within, you know, a very short period of time, within a few milliseconds or, you know, half a second or something, it drops back down all the way back down to baseline. So I touch my forearm, I get a burst from the phasic receptors, then they drop off. But the tonic receptors are still on in the background, so if I think about it, I can still tell something's pushing on my arm, right? And then when I release this, it also creates a stimulus, the off response. So when you change that position and change the deformation again, it causes another depolarization, and when you do the off response. So that just shows you the tonic versus phasic receptors. Okay. You've stimulated a receptor, free nerve ending, mechanoreceptor, thermoreceptor, chemoreceptor, and now that action potential is going to get sent in a nerve. median nerve, ulnar nerve, femoral nerve, whatever. And that nerve is made up of a bundle of axons. Okay, so in any nerve, you typically have sensory axons, motor axons, and autonomic axons. Those in any nerve out in your periphery, nerve trunk, or nerve itself, you're going to have a combination of those. Okay, and so within that nerve, you're going to have different types of classifications of axons depending on what they're carrying and how fast they're carrying that information. Okay, so we're going to talk about just sensory axon classification. So axons that carry afferent sensory information. Next week we'll talk about motor. There's also motor axons that also have a classification to them depending on their diameter and myelination. So we're talking sensory, peripheral neurons. Okay, these are afferent nerve fibers or axons. Remember, the cell bodies for most peripheral neurons are located outside of the spinal cord or outside of the brainstem, okay, in a dorsal root ganglion or a cranial nerve ganglion, okay? So if you remember, talk about cell types, we have a pseudo-unipolar cell, our sensory neurons, here's our peripheral receptor out here, here's our Pacinian corpuscle, but this cell body is out in the periphery, in the dorsal root ganglion, which is this little area just before the dorsal root enters into the spinal cord. That's where the cell body, and it separates into a proximal axon and a distal axon. Okay, but the axon itself here, this is what we're talking about. This is a C fiber or something like that, or an A delta fiber, an A beta fiber. It's that axon classification based on its diameter and how myelinated it is. Okay. So here is your classification going from slowest to fastest, okay, for our primary axons that carry somatosensation. So here's our C fibers, which are our slowest. That's what our slow pain is carried on. That slow aching pain is these C fibers. That's only 2 meters per second. So it takes a full second for, for that slower pain. It takes a whole second to get from, say, if you're 6 feet tall, to get from your foot to your brain to register is a full second, which is 1/1000. That's kind of long. And when you're talking, most other things are milliseconds it takes to get there. The next one is your fast pain, which is A delta, which is 45 meters per second. And then we start talking the type 2 or the A betas. Those are both about 90 meters per second. 1Bs are about 120 meters per second. And the 1As. So when we start talking about muscle spindles and joint receptors, this we're talking about here, because these have to be really fast because they're giving you feedback about helping you to maintain your balance and turn muscles on and off appropriately very quickly to respond to perturbations in balance and those kind of things. So that's why those are so much faster. I mean, still fast is relative here. 45 meters per second, that's still pretty darn fast, but 120, 130 meters per second, that's really fast to get that response, okay, that you need, and get that information into the spinal cord, up to the cerebellum, processed as the next signal sent down to then make a correction if you need to based on the sensory feedback you're getting. So this is just showing you, here's our dorsal root ganglion. There's more than one in there. So, I mean, this is typically, so here's a sensory receptor out here. Here's your peripheral axon, but you've got, lots of sensory receptors out here, and you have lots of sensory axons coming in here, and so you have cell bodies, lots of cell bodies in here, okay? But depending on, like, if this is a free nerve ending, this might be a C fiber. This one right here, this Pacinian corpuscle, it might be more of an A beta fiber, a little faster, so that's the classification based on the type of information it's bringing and how the diameter and the myelination of that. Okay, so then it comes in the back part of the spinal cord. And then it becomes part of the sensory pathway to go up the spinal cord, which we'll talk about when we get to pathways. Another concept as far as the sensory experience is this thing called receptive fields. Okay, and this has to do with more superficial sensation. Okay, so you have these receptors, okay, and in this case they're showing them as free nerve endings. They don't have to be free nerve endings. They can be a more specialized receptor. But here's an actual individual neuron, the yellow, and another individual neuron, the blue. And they are attached to these receptors, right? And these receptors, here's the yellow and here's the blue, sometimes the area of skin that they innervate or take information from, okay, overlap. And so this, see the overlap there of the blue, right? There's the overlap. So each of the individual yellow is a sensory or receptive field. The blue is a receptive field, okay? But there's overlap of those receptive fields. And the smaller the receptive field, the more of them you need to cover a certain area, right? Okay? So if I've got a certain area of my arm, and if I have real small receptive fields, I need a lot of those little receptive fields to cover. And there's also a better chance that you're going to have a lot of overlap of those little receptive fields. Versus if I just have one nerve that goes to a big region of my arm and just you have a receptive field, a big part of my arm that's only one nerve is gathering information from or innervating that one large receptive field, okay? So the reason why receptive fields are important is because if you're doing fine touch, or we call discriminative touch, like the ability to distinguish between 2 points and how close those points are, all depends whether it'll fall in one receptive field versus falling in more than one receptive field. Because in order for you to actually experience the sensation of 2 points, it has to fall in 2 distinct separate receptive fields. So those 2 signals are sent separately up to the cortex, and they say it recognizes that those as 2 distinct separate signals to say, aha, I got touched by 2 separate things. It has to fall within 2 receptive fields. So if I'm doing 2-point discrimination and I'm testing somebody, and if I have these let's say these are fairly large receptive fields, you see if there's a chance I could put these 2 points, and let's say this is 6 millimeters apart. If both of those points fall into one receptive field, and I ask the person, did you feel 1 point or 2 points touch you? If those both fall only on the one nerve, they're only going to experience it as one sensation of 1 point that they're feeling. It won't allow them to discriminate between those 2 points because there's just one signal being sent for both of those points as long as they touch at the same time. You know, if I went boom, boom, and touched one, then the other, there might be a little temporal difference, and then your brain would notice that 2 points touched you. But if you touched with the 2 points at the exact same time and they both landed in just one receptive field, you would only feel that as one point of information. It'd feel like 1 point just touched you. However, if you touch your little stimulus here and it happens to fall in 2 separate receptive fields, then you will identify that as 2 points touching you at the same time. So if I have small receptive fields, lots of small receptive fields that are all overlapping, then the chance that even something with very small differences in texture and points will fall into 2 separate receptive fields and will give me more high-level definition of my sensory experience up in the cortex. So that's why the tips of our fingers, our tongue, our lips have very high density of receptors and small receptive fields because you manipulate objects. I want to be able to feel every texture and little bump on this thing and be able to feel that zipper and grab it appropriately and know where the edges are. The more receptive fields and the smaller they are, the more, what do you call it? The more, not complex, but the more you have as far as, what's that? Precise or precision or amount of information that gets in. It's much more a richer experience that you're getting from that, okay, as far as texture and all that kind of stuff, because you have all these little points falling on different receptors that give you more of a true picture of what you're touching and what it feels like. But there's other places on our body it doesn't really matter. Our butt, our back. We're not manipulating objects with our butt and our back, hopefully. So when you don't want extra sensory information coming in to distract you from the important stuff, like what you're feeling with your hands. So in your back and your butt and the back of your legs and the front of your thighs, you have these massive receptive fields because you don't need that much of a rich experience of sensory information coming from certain parts of your body. You just need to know if it's in pain, gross pain, position, but you don't need to know exactly every detail of what's you're touching with your leg or your back or your butt, okay? And so different regions of our body have different size receptive fields. So in my back, in my butt, and back of my legs, I have these large receptive fields that are supplied by just one nerve. And there's actually less sensory information coming in from certain regions of my body because it's just not that important than from my face and from my fingers. And when we look at the cortex on the brain, you'll notice that the amount of cortex in your brain that's receiving that information is proportional to the amount of receptive fields that you have that are actually individual neurons bringing in that information. You need more processing area up in your brain to process all that extra sensory information coming in. That's why we do the 2-point discrimination testing. I don't know if we've showed you guys that. You can actually, we'll try to, on Friday, have a little sensory testing lab. We'll go in the lab for a half hour, review some sensory testing, and we'll show you some, the 2-point discrimination is a test you do to see how somebody's receptive fields are doing. So I don't typically do it. It's usually more of an OT thing, especially if they're talking about trying to test if somebody's going to be able to do things like button their own shirt, manipulate objects, and think more fine touch. I don't do much of that, but it's good to know, okay? This just shows you some of the relative, I don't know why they have the person like this diving, but anyway, I guess it works. The relative receptive fields in different locations of the body. So on your back here, 42 millimeters, that's a pretty big receptive field. So I'd have to get like calipers that go farther than 42 millimeters apart to place on your back to likely get you to know whether I'm touching you with 1 point or 2 points. If I don't go bigger than that, there's a chance I'm just going to fall in one receptive field that's supplied by one nerve. And so you're only going to, even though I've got this wide caliper and I touch it on you and I say, how many points just touched you? You might just say 1. But if I go wider, then there's a better chance I'm going to actually hit 2 separate distinct receptive fields on your back. And so you can see here's the index finger, the thumb, the lip are much smaller. Forearms pretty big too. So you just don't do much with the back of your forearms, or you're not manipulating objects with your forearms. Same thing with the calf. Big toes, smaller. There's a little, people do. You do stuff with your toes. You're feeling the ground. You're manipulating some things sometimes with your feet. So we're still on this concept of superficial sensation. We just talked about receptive fields. Now we're going to talk about types of skin sensations. And this is just more definitions, terminology to make sure we're all on the same page of what we're calling certain types of sensations. So there's what we call fine or discriminative touch. Fine discriminative touch. This is the touch where, again, you know exactly where you were touched, or as you're feeling an object, you feel the ridges, the furrows, the texture of that object. This is fine discriminative touch. The receptors that are stimulated when you're, for this fine discriminative touch is going to be these more specialized receptors that have specialized endings because they're going to bring that special information that's very, refined and specific. So things like Meissner's corpuscles, Pacinian corpuscles, Ruffini's corpuscles, Merkel's discs, and even hair follicle receptors. And these are all considered mechanoreceptors, okay? But they're more specialized in nature. Those all contribute to fine touch. So anytime you hear about a corpuscle, or a disc or something like that, it's going to be associated with this fine discriminative touch, okay? Then we have coarse touch, which is this poorly local, yeah, sorry.
Do you want us to, specifically, if it's sensitive to pressure or light touch or vibration?
We'll get to that. I have a little chart or table that you can use to kind of help you understand that. I like to try, if you can group things, we'll get to that in a second, but yeah. Coarse touch is more poorly localized, this tickle and itch kind of sensation that we get. Just like, yeah, I can tell you're rubbing my arm here, but I can't exactly point to it, or boy, I just feel a little itch or tickle there, but I can't exactly tell you exactly where it's coming from, but I know it's coming from that area of my arm or leg. That's coarse touch. That is actually mediated by, or the receptor used there is free nerve bendings. Those are free nerve bendings being stimulated to an extent. So it's the non-specialized types of receptors. It's the free nerve ending, acting as a mechanoreceptor in this case. Okay. So remember, free nerve endings can act as a mechano, thermo, or chemoreceptor. In this case, they're acting as a mechanoreceptor. Then we have pain. Pain is a skin sensation that we can have, and it's mediated by what's the receptor is always a free nerve ending. It's just that you exceed a certain threshold for it. Whether you're stimulating it with temperature, it could get so hot that it becomes painful because there's a threshold that once it stimulates it's feeling warm as a thermoreceptor temperature, but eventually if it gets too hot and crosses a threshold, then it becomes pain. Okay. But these free nerve endings, or if you push on it or stretch it to a point where tissue knows this is a point where it could cause damage, then that free nerve ending is going to send a strong enough signal that you're going to perceive it as pain. Okay? Pain receptors as a class are all referred to as nociceptors. So all nociceptors are free nerve endings, but if they actually elicit pain, then it's a nociceptor. So a free nerve ending that elicits pain is called a nociceptor. And it can be either mechanical in nature, you stretch or pull on it, and it crosses a threshold of stretch that it says pain now. Now I'm a nociceptor, I'm signaling pain. Or it can be too hot or too cold, where you get tissue, again, being recognized that could be damaged by the heat or the cold, and then it becomes pain, and now it's a nociceptor, it's free nerve ending still. Or a chemical, so you've got tissue damage in the area, you've got substance P or histamine that's falling on these free nerve endings. You get enough of that falling on those free nerve endings, that's also experienced as pain because they know tissue damage has occurred around that area. Now these chemicals that are coming from cells that have been damaged or ripped open are falling on these free nerve endings and causing pain. And again, now it's a nociceptive, this is a nociceptor, okay? Then lastly, temperature. Again, those are free nerve endings acting as thermoreceptors. You cross a threshold, though, and it becomes a nociceptor and a painful experience. Okay, but before that, it's just a thermoreceptor, and it's just telling you about gradations in temperature, hot or cold. Just showing you this is more the superficial skin experience here. Now you have your epidermis here, and then dermis down here. But you can see this is just showing you generally where some of these different receptors lie within the layers of the skin here. So here's a Ruffini ending, Pacinian corpuscle. We've got some Meissner corpuscles here. Here's a Merkel's discs right here. So those are more specialized. They have some kind of look to them that looks somewhat specialized. But then here's our free nerve endings. So just free nerve endings, which is what they look like. And this is a hair follicle nerve ending. It's also called a peritracheal nerve ending, or it just wraps around the hair follicle. And those are actually, pretty good at telling us about, especially as you start having something moving across your skin, which way it's moving. That helps to, which way the hair is bending forward or backwards, side to side. It gives us some experience of how things are, especially if things are sliding up and down on our skin. Okay. And this is hairy skin, you can see here. So hairy skin tends to have more of the Merkel's discs in it, where hairless skin tends to have more of the Pacinian and Meissner corpuscles and so forth. Don't worry, that's not as critical to know. But so here's a nice table that summarizes all the different, first of all, receptor types. So on the very right-hand side is the receptor types, okay? So your free nerve endings, Meissners, Pacinians, Merkels, Ruffinis, muscle spindles, Golgi tendon organs, and joint receptors. It tells you about the anatomical characteristics. Not that critical to know. Just know whether it looks more encapsulated or specialized or not. And so really most of these are all specialized except for the free nerve endings. Okay, so all of these are fairly specialized in nature. They're encapsulated or specialized in some way, but that's all you really need to know. And the free nerve endings are not. That's kind of how I would group those. Then you have, what are the axon types associated with those? They're going to be carrying, proprioception or pain up an axon of a certain diameter and certain myelination, okay? So free nerve endings are typically going to carry information that is either on a C fiber or an A delta fiber, fast and slow pain, okay? and it tells you general location. Again, this is not that important to know, so I'm kind of crossing that out. But then now look at the next, look at all these. Here's another way to group these. So all these corpuscles and discs are all A betas. So that just, okay, if it's a corpuscle or a disc or something like that, that's an A beta fiber. It's faster, still pretty fast, not the fastest, but it's getting there, 90 meters per second kind of range. Then we get to muscle spindles, and that's going to be 1As and 2s primarily, okay? Those are the two types of axons that carry information from muscles. Those are really fast, the 1As and 2s. Those are your 130, 120 meters per second. And then lastly, we have our Golgi tendon organs, which are 1Bs, okay? Don't worry, they don't even say anything about the joint receptors here. The joint receptors are a mix, are quite a mix of different ones. But so that's kind of how I group those. So free nerve endings, C and A delta, all the corpuscles and discs are A betas. And then we've got our 1As and 2s for muscle spindles and our 1Bs for Golgi tendon organs. Okay? Here's the function. I would generally know this is free nerve endings, pain and temperature. All of these other ones, these corpuscles and Pacinian discs and corpuscles, I would just classify all those as kind of more superficial proprioception. You know, superficial proprioception on what's happening with your skin and how, with pressure, movement of the skin, vibration, those kind of things. I wouldn't know. I wouldn't try to go in and this is pressure dynamic and this is deep pressure. Don't worry about that level. Just know that this is more superficial proprioception. Yeah.
I was going to ask, like, why is the free nerve endings, like, dealing with pain, why does that have slower associated axons? Like, wouldn't you want them to be faster?
You would think so. The pain is actually so. The stimulus is going to get there eventually, but it's still fast. It's still relatively fast. I mean, it still happens within a relatively fast time frame. If you're the fast pain's coming up on these A deltas at, you know, at 45 meters per second, and so that's still fast enough to move your hand reasonably fast before much more, say, tissue damage occurs. However, the other ones, what the problem with the other things is you got to send the signal, let's say for your feet, you've got to send joint receptors and muscle spindles are going to have to send a signal. If I start to fall forward and I need to pull myself back, I need to send a signal all the way up, get it processed, and then have time to send the signal all the way back down to cause the muscle to change contraction before I've actually lost my balance to a point or gotten to an extreme of a position that I can't recover that position. So I don't know if that helps, but it's more about protecting you from falling, and there's a little bit more of a processing thing that has to occur up and down. And although you still have to do that with pain too, you still have to get there, and then you have to pull your hand away or move your body away from the painful experience. But yeah, I don't know exactly. So okay. Then muscle spindles, the thing they mainly detect is muscle length, how long your muscles at any given moment and how fast it's changing, the length of your muscle is changing. So it tells you about how long is my muscle at any given moment, and then if it's changing length, how fast is it changing that length. Okay, that's muscle spindles. Golgi tendon organs, then the tendon of the muscle, tell us about tension. Tension in that musculo-tendinous junction, how much tension is happening. And then your joint receptors, it makes sense, joint position. Okay, so that's kind of how I group all these. Then I can remember the rest are kind of, if it's a muscle spindle, it makes sense, muscle length. If it's a joint receptor, joint position. If it's a tendon, tendon tension. I think, you know, that's monitoring tension. And then special eye or the free nerve endings, pain and temperature. Make sense? So everything else, this is I wouldn't worry too much about rate of adaptation right here. This wouldn't be something that's too big of a priority for me. Threshold of activation for pain and temperature and the free nerve endings, it tends to be a fairly high threshold of activity. You have to exceed a certain threshold to get it to cause pain or to get the temperature to change and to experience that change in temperature. It's a fairly high threshold. Everything else is low threshold, especially all these other proprioceptive things. It doesn't take much for you to be able to tell that you don't, I mean, I can barely move my finger and I can still feel it moved and how far did it move and so forth. We get this very rich proprioceptive experience because our bodies are always needing to know where they are in space at any given moment to deal with the world. So all the rest are low threshold activation. Let's get through a couple more things and we'll take a break. So still on the concept of superficial sensation, you guys know about dermatomes, right? Area of skin innervated by a single spinal nerve, and that, remember, that came originally from that area of the somite, with the neural crest cells that grew into our peripheral axons that go to that region to become then part of your skin. So that's how it all started. From a standpoint of dermatomes, clinically, probably the most important ones for you guys to know as you progress in your clinical career is going to be really understanding where the C5 to C8 dermatomes are and the L4 to S2 dermatomes. Those are the ones that are most involved with back and neck problems, okay? Or if you have a spinal cord injury, the most common level of spinal cord injury is around C5, C6. If people do get a spinal cord injury, it's more common to break your neck because it's more vulnerable, and it's the mechanism, you know, a car accident or diving or something like that. And it tends to happen in that kind of mid to lower C-spine for most people. And so just knowing those dermatomes really well. The other ones you can kind of reason out. You know, when you start getting the thoracic spine, the dermatomes are kind of aligned with the thoracic level that you're at, okay? So, but these are the ones that you really kind of want to know carefully for your clinical perspective. And then we have our peripheral cutaneous nerves, right? So we have, as you start to go further out, you have your branches to your final nerve that supplies a certain region of your skin that's associated with that specific peripheral nerve, okay? And so for the upper extremity, the most important ones are going to be like your median, ulnar, and radial nerve distributions. Knowing those peripheral nerve distributions, if you damage the nerve more distally versus if you damage it up at the nerve root, okay, how that's going to express itself as a loss of sensation or a change in sensation. For the lower extremity, it's more the femoral and superficial perineal nerve. Those are your two big ones that supply a lot of your lower body that are more likely to be compromised. People do get femoral nerve impingement, you know, in their, where, you know, is going through that inguinal area there. Or superficial perineal nerve is very commonly involved with injuries, or, you know, somebody falls asleep with their leg against a hard object for a day or two, or passes out and wakes up and can't move their foot, or gets damaged by something hitting you in the, you know, right there below the head of the fibula. Those are common places to have injuries or you know, difficulty with those peripheral cutaneous nerves. I actually had this book. I hope I still have it. So somebody gave me a book that was like this old neuroscience book, and this is how they expressed and showed dermatome levels. This was the picture that they used. So it's kind of like, well, I can't see all of the dermatomes there, you know. So I tell you, it's just kind of be very, you know. So let's see here. Yeah, it would be really hard to get dermatome levels off of this, I would say. I would not use this in your on a quiz for a diagram or anything like that. So here is from your book, more of a dermatome. And if you look at dermatome charts, whether it's Donna dermatome or from your thing, there's a lot of variation. I mean, so the other thing you have to know is these are not clean lines. Dermatomes overlap by a good level or so. So even though you lose a certain level of a dermatome, usually you'll have some overlap, so it's not always cut and dry. Okay, so when we get to spinal cord injuries, I'm going to talk about loss of sensation dermatonal level-wise. You may still have some dermatonal level that you don't expect to have because there's overlap of dermatomes. So don't go by just these pictures, but you just need to have some general perspective on where most dermatomes are. So as you're evaluating your patient and you're putting together all the parts of your information that you're getting from your patient, sensation is one part of that, motor, reflexes, all that. You're starting to build a picture to say, I think that nerve root's involved, or it's that peripheral nerve that's involved. This is just one piece of information to help you understand that. Okay? And the newest edition of your neuroscience book does a nice job of kind of showing you how dermatomes versus just the peripheral nerve distributions are related. I don't know if the fourth edition, but the fifth edition has a nice little diagram showing even from the development of the somite and how those are innervated, and then how that goes from a dermatonal, and then as it starts to go branch off, where it goes to more the peripheral nerve distribution, and how the relationships there. So, any questions on superficial we're just kind of finished more superficial sensation.
So the receptive fields and dermatomes are a little different, or they kind of the same as far as like
So if you have a dermatome, you'll still have receptive fields that are associated with axons that are supplying that dermatome, but all those axons are going to end up going in through that one spinal nerve root. Does that make sense? So it's not like it's one. You may have lots of receptive fields in that dermatome, but every axon that's going to that dermatome, that will contribute to the nerve, starting out as your peripheral nerve, that then build in and go into your spinal nerve, that would give you the representation of that dermatome. But you may have hundreds of receptive fields within that dermatome that are supplied by hundreds of axons that form the spinal nerve root, all the sensory neurons for that spinal nerve root that go to that area of skin. Make sense? All right. Let's take a break. Come back in 10. Forward. And starting with the muscle spindle. Okay, so we're going to talk about the muscle spindle now as it relates to sensory experience, but we'll also talk about the muscle spindle when we get to motor, because it influences motor output as well, definitely through that stretch reflex and so forth. But we're just going to focus on the sensory part at the moment here. So muscle spindle, it's embedded in all skeletal muscle. Okay, so skeletal muscle is where muscle spindles are. What does it do? It detects the length of your muscle, how long it is at any given moment. It also gives us an idea of how fast that length is changing. So if it is actually changing length, how quickly that's occurring, because that's going to be important for our body to know as far as controlling movement and motion and dampening responses and those kind of things. So detects length and rate of change in length. It consists of these fibers, okay, that they're called collectively intrafusal fibers. And fusiform is where something's tapered at each end. So your muscle spindle is tapered at each end. So within this tapered spindle, this fusiform structure is these intrafusal fibers. Okay, and this muscle spindle is embedded, in your muscle. Within the muscle spindle, there's two main types of fibers. There's what's called the nuclear bag fibers, which is there's a clump of nuclei in the middle. That's why it's called, it's like a bag of nuclei. Okay, there's a little bit of a bump in it in the middle. It's a little bit thicker and bigger in the middle. Then there's the nuclear chain fibers, which are basically little nuclei that are aligned in this fiber that are all lined up one after the other in a chain. Okay, nuclear chain fibers. Okay. There are afferent nerve endings. So afferent is sensory nerve endings that are going to these intrafusal fibers, right? Or coming from those fibers, right? Because they're going to be taking information towards the spinal cord, towards the central nervous system. So we have afferent nerves that take information from the intrafusal fibers to the spinal cord and to our central nervous system, okay? There are two different types of afferent nerve endings that are supplying or connected to these intrafusal fibers. There's what's known as the primary nerve endings, also known as the annulospiral nerve endings, okay? And those nerve endings are sending the information on axons that are classified as 1A axons. They are the fastest axons that you can send information on. So those primary annulospiral nerve endings are classified as 1A. There's a phasic component. Part of it's phasic and part of it's tonic. The phasic part has to do more with some of the rapid changes in muscle length. The tonic part has to do with once your muscle has achieved a new length and it's staying at that new length. It will continue to tell your body what that new length is and continue to register that length of that muscle. That's the tonic part of it. The phasic part is it tells us how rapidly you get this burst of feedback and impulses when your muscle's changing length rapidly, either shortening or lengthening. Okay, that's the phasic part of that response. Okay, and then we have secondary or called flower spray endings. Okay, that are also just afferent nerves. These are a little bit slower, class 2 axons that this information is carried on, and they are just primarily tonic in nature. They're just another signaling of your muscle length at a given point in time. They don't detect the rate in change of length as well. They're just more about, again, another signal telling you about how long your muscle is at a given point in time. Okay? We're going to focus on the afferent part right now, but you do need to know there's also an efferent. There's actually motor signals being sent to the ends of your muscle spindle. Your muscle spindle can adjust its length with inside of the muscle. So they are called gamma motor nerves. Okay? Gamma motor nerves go to these little muscle fibers that are the ends of each of your muscle spindle, because what you want to do is as you contract a muscle, you adjust your muscle spindle to lengthen or shorten within that muscle so it'll stay sensitive to stretch. Okay, that's how you adjust the gain or the sensitivity of your muscle spindle, by adjusting the length of the muscle spindle as it sits within the muscle. Because as you shorten a muscle, if your muscle spindle gets too slack, it no longer can do a very good job of registering information. So what it does is as your muscle shortens, your muscle spindle will shorten with it. So the next time you get a stretch that lengthens it, it's ready to be stretched again. If it just gets slack, the next time you lengthen your muscle, it's going to have a delay in its response because it hasn't been shortened with the muscle. So it just adjusts the sensitivity of the muscle spindle to match the muscle length a little bit better. And so that's what the motor part of the interfusal muscle fibers here, these gamma motor nerves, to maintain the length of the muscle spindle. When we get to the motor influence of the muscle spindle, we'll talk a little bit more about that. Why won't you? There we go. The only thing this is just a picture I added to the presentation just to show you. Here's our muscle spindle. This is a fusiform structure tapered on each end with the interfusal fibers. You have multiple nuclear chain and nuclear bag fibers sitting in there. Okay? At the ends, you have some little intrafusal motor or muscle fibers that are being supplied. These things in green, those are the efferent gamma motor neurons that go to the little muscle fibers at the end here of each muscle spindle. So, and because the muscle, the motor nerves that go to your actual muscle, the extrafusal muscle fibers of your muscle, are called alpha motor neurons. These are called gamma motor neurons. So that's what these are going here. But the rest of these, all the stuff in blue, those are your annulospiral, okay, and primary nerve endings, and now your secondary or flower spray nerve endings. This is the afferent part, the sensory part of the muscle spindle that registers that length of the muscle and the change in length of the muscle. So now we're just going to make this a little bit simplistic, little easier to see, is we're going to take one nuclear chain fiber and one nuclear bag fiber out of this muscle spindle and look at how the afferent axons interact with that and bring sensory information from those. So we're focusing on the afferents right here. Okay, those are the sensory axons. So here is your primary nerve endings, is what's in blue here. We have our these are the annulospiral fibers because they spiral around and wrap around or encircle both nuclear chain and nuclear bag fibers. Okay. The part that wraps around the nuclear bag fibers is considered the phasic part of that. Okay, because the fact that you have this kind of a little bit of a looser bag of nuclei that are all kind of near each other, it does a better job of actually registering quick changes in length, because as you start to change the length of the muscle, there's more ability for that nuclear bag fiber to deform and actually change shape, and also for those nuclei to kind of slide over the top of each other and give you this burst of information about how fast is my muscle changing length right now, as it's actually changing length during a dynamic movement. Okay? Once I've achieved the new position, then you use mainly the nuclear chain fibers, which are kind of lined up all together. So they do give some information about change in length, but once they've achieved a new length, they're either got more tension or less tension in them. And it's that now that you've achieved a new length, that's where you get more the tonic information about the new position of your muscle at a given moment in time, not as it's changing length. So the static or the nuclear chain fibers give a better indication of just the length, the new length of the muscle that it's at. Where the nuclear bag are giving you more information about how the change in length as it's occurring. Does that make sense? Because these guys can move around each other. There's a little more slack in the system. So they're ready to actually give you more information about the rapid changes in length that are occurring, where these lined up ones just tell us more about, okay, now I'm this length, now I'm this length at the time at any given moment, not as it's changing length. Doesn't mean they still register some information about change in length, but they're better at the tonic new length of the muscle, where the nuclear bag fibers are more phasic in nature. And then here's the type 2 fibers here. This is the flower spray. They kind of sprays out. Now they're showing it wrap around a little bit here. May wrap around some, but it also kind of sprays out in this arrangement here. Flower spray, secondary nerve endings, type 2 is the type of axon. A little slower than the 1As. The 1As are a little faster. They're giving you a little more richer, faster information, but this is more in the tonic type of new change in length, that background information about your muscle length. Okay? And this is the motor part. So these are the motor fibers. And you would have them on this side too. They would go to both sides of the ends of the muscle spindle to adjust. They can adjust the length of those muscle spindle fibers according to how long your muscle is, to maintain a certain amount of sensitivity of the muscle fiber. Okay? Because if you didn't, it would just go silent. So what happens if you shorten your muscle really short, your muscle spindles would just go, they would just gather up and they would lose their ability to send signals. You actually have to tension them up too, so the next time you lengthen your muscle, they're ready to send another signal right away, and they're not just on slack and kind of like wobbling there, and then it takes an extra delay before it starts to send another signal again about change in length. Okay. Any questions on muscle spindle? Muscle spindle, muscle length, change in length, rate of change in length. The other main one we're going to talk about that tells us about something about our muscle and our tendon is the Golgi tendon organ, GTO. This senses tension in the musculotendinous junction. Okay, so here's your muscles, here's your tendon. So you have this somewhat specialized. Actually, they say it's highly specialized. It looks like a free nerve ending there, but it's actually somewhat encapsulated and is actually highly specialized. This Golgi tendon organ. It is embedded in that musculotendinous junction and kind of woven into the tendon, and it registers tension. Okay. And because it's kind of registering tension throughout here, it's telling your body about how much tension is happening at each one of these sites between the muscle fibers and where they interact with the tendon. And what it can do is actually, it helps to spread load evenly across the musculotendinous junction. So if you're contracting a muscle, and let's say these muscle fibers out here are sensing extreme amounts of tension, and it may be an extreme enough amount of attention that are worried about tearing that musculotendinous junction on that side. Okay? So what the Golgi tendon organ will send signals back to your spinal cord to say, let's decrease the amount of muscle firing of these two muscle fibers, but let's increase these guys a little bit. So it tries to balance out or even out the amount of force that's being produced at that musculotendinous junction. Okay? They used to think that GTO was this fail-safe thing where, like, if you had too much tension and your muscle thought it was going to be damaged, it would just shut off and it would actually turn your muscle off so you don't hurt yourself, so you don't tear your own pec when you're doing a bench press or something like that. It's like a safety valve, but it's not that. It's not just an off switch for your muscle when it thinks it's going to be injured. It actually helps to, it may turn some muscle fibers on, or it may turn some down, or, so it tries to balance tension across the musculotendinous unit. Okay, it's a little more fine tuning what it's sensing there. Make sense? And that information, the type of axon, is classified as a 1B afferent. Fast, it's very fast, just a little bit slower than the 1As, but really pretty fast. This is important information to protect the joint. Then we have these joint receptors. So joint receptors have their own types of receptors that are somewhat analogous to some of the peripheral sensors in your skin. And you'll see here, they have Ruffini endings. They have Pacinian endings, okay? So there are some names that are similar to what you see in some of the skin receptors. You have, because they're probably found by the same person. Ruffini found these same ones, and they look similar in the joint as they do in the skin. Same with the Pacinian, whoever Pacinian that found this, and found that there are also some in the joint versus the skin, but they look similar in their form, okay? I tend to think of these, and when you look at research and when you do your reading, is more by the type. Type 1, 2, 3, and 4 is probably more important than knowing Ruffini, Pacinian, ligament, free nerve endings, but type 1 through type 4 is probably something you'll see more often in your reading and when you get into ortho, okay? Type 1s, they send their signals on type 2 afferents. They tend to sense or be stimulated with extremes of joint motion. So you don't stimulate these Ruffini or type 1 endings until you get to the very end of a joint motion. That's when they tend to send their signals to tell you, hey, you're at your end point of this joint motion. Pacinian endings, or type 2, also send their signal on type 2 afferents. They are mostly active during very dynamic motion. So while your joint is moving, and the faster your joint moves, the more though you're going to stimulate these type 2 Pacinian endings. They're very sensitive to rapid changes in length of the joint capsule. Okay. And they actually, when you massively stimulate type 2 mechanoreceptors, that information goes back to the spinal cord. And actually what it does is it'll send a brief burst of inhibition to the muscles that are near or surrounding that joint. So one of the theories about, like, when you get your back or your neck snapped or cracked, is that part of that, when you do that whip fast crack, the release of the nitrogen or whatever causes the crack isn't the thing that makes you feel good or relaxing you. It's this rapid and massive stimulation of type 2 mechanoreceptors that goes back to your spinal cord, and what it does is it goes back to your joint and says, I'm experiencing rapid, super rapid motion. Turn muscles off so I don't damage the muscles during this rapid motion. Don't resist it and cause injury to yourself. Just let it happen and relax a little bit. So when somebody snaps your neck like that, it actually happens, though, after it's already happened, even though it's trying to somewhat protect, but you feel this massive like relaxation of those muscles. But it only lasts briefly, and then about 10 minutes later, you're tightened up again. But there is some theory that's why people experience that relief or release initially, is because you're stimulating type 2 joint receptors during grade 5 manipulations. We also have ligament receptors. They're like the GTO. They do the same thing. They sense tension in the ligaments instead of the tendon. Okay, so the ligaments, the attachments between bones, have these sensors that sense tension. And then we have free nerve endings. We also can have inflammation and pain that's sensed in our joint as well. So those are the type 4 free nerve endings. Those are joint receptors. This is just showing you some of the types and locations. This picture's from your Ekman book. All right, so that was musculoskeletal or deep sensation, a little more, depth, no pun intended, on the deep sensation. Um, are you guys ready for pathways to start working our way up? The pathways are not that hard, really, especially sensory pathways and even some of the motor. If you break down the terminology or the name, it often tells you where it starts and where it's going, or gives you some idea of where it starts and where it's going. And and it's just like wiring. It's just one connected, the next one's connected to the next wire, to the next wire. So we'll try to make this reasonable and not too overwhelming. I'm not crazy about the way your book uses the diagrams they use in them and the way they approach this. I don't know how people felt about the reading. Did you just feel kind of like, after you got done, like, what did I just read? Or I don't even know what I read, or how it all related. That's normal, and the book does not do a great job. So hopefully I can complement that, but I'll use the book's diagrams just so, because when you're thinking about it, and I'll draw on the book's diagrams, that when you look to the book again, hopefully it makes more sense, there's a little more clarity. So, all right, so here we go. This is from that same book with Donna Dermatone. I thought it was kind of a cool little abstract artwork there. I could see that. Put that on my wall, black light poster of some type or something. That would be pretty cool. So this is just sensory pathways. So what are the key pieces of information you want to make sure you know about each pathway? These are some of the key pieces. You want to know, all right, what type of modality of sensation is this thing carrying? Is it proprioception? Is it temperature and pain? What is the modality it's carrying? Okay. You also want to ask yourself, does it cross the midline? When I say midline, when we take the nervous system, brain, cerebellum, brainstem, spinal cord, and we draw a line right all the way down the middle of the entire central nervous system, all the way down through the spinal cord, divide things into a left and right side, does it somewhere cross that center part of our nervous system? If it does, you want to know where it crosses. Okay, generally, where does it cross? Does it cross in the spinal cord, the brainstem? Where does it cross? Where does that crossing happen? Okay. And then we'll get into doing a little bit of this, of trying to figure out if a patient presents with damage to a particular pathway, how will they present? What will you expect to see if they have damage to that particular pathway? So those are some of the key things. And so if we look at this table here that I've got for you, these are all the pathways we're going to at least talk about or mention today. We may not get through all of them today. So here's the first thing. The first column you're going to write is like the primary sensory modality, like conscious proprioception, temperature, pain, unconscious proprioception. That's what you're going to be writing in that particular column. This is your peripheral nerve class. Okay, so this is what, if you want to put in the sensory modality, you could even put the type of receptors like Pacinian corpuscles or something like that, but you don't need to get that detailed, or free nerve ending when you talk about the sensory modality. But then the peripheral nerve class is the type of axon that information is going to be sent on. C, A delta, 1B, A beta, that kind of stuff. That's what you're going to be putting in that column. Okay. Then we're going to be talking about primary, secondary, and third order or tertiary neurons in the pathway. Okay. If the sensation makes it to your cortex and you have conscious awareness of it, it's going to have 3 neurons in the pathway. If it stops before then, if it stops in your brainstem or your cerebellum, it's only going to have 2 neurons. So in some of these pathways, you're going to put NA on that 3rd neuron involved there. Only if it makes it up to the cortex is going to have that 3rd neuron in the pathway. Okay, so the ones that we're going to talk about that get conscious awareness of, those are going to all have 3 neurons in the pathway. And you just want to say, where's the cell body at for these? For the primary neuron, for example, where's the cell body? Where's that first neuron ascending in the CNS? Where does it start out ascending? Then where does it make its first synapse? Okay. With the second order neuron, so you have first order, second order, and third order neurons here. Then the second order neuron, you're going to ask the same thing. Where does the cell body start for that second order neuron that's been communicated from that first order neuron? Now where is it ascending? Because sometimes it'll change. Just like streets in Dayton, Ohio change when you cross one street, sometimes the names change for pathways as you go up from one order neuron to the next order neuron or to a different region. When you go from the spinal cord up into the brainstem, it may change names, like from the dorsal columns to the medial lemniscal part of it. So that's what you want to write in there. And then if it does cross, and then maybe where it crosses, like spinal cord, low medulla, high medulla, that kind of stuff. But mainly, most places these places cross is going to be either the spinal cord or the medulla. Is pretty much where all the crossing is going to occur here, at least for sensory pathways. All right. So let's go through, and we are now on this diagram. We are right in here. Okay, so we're going to start talking about these main primary pathways for sensation. We've already talked about all the other stuff on top there. The first one is conscious proprioception / discriminative touch. Okay, this is the information. Well, I'll get to it in a second, and this is going to be carried on for the body. It's going to be carried on what's called the dorsal column medial lemniscal system. Okay, that's for the body. For the same modalities, conscious proprioception, discriminative touch from the head and neck region, somewhere of the neck and head, that's going to be carried on the trigeminal tract, it's called. Then the next major pathways or area of somatosensation is this thing collectively called unconscious proprioception. So unconscious proprioception are going to be all carried on what's called the spinocerebellar tracts. Then lastly, we have what's called the pain, temperature, and coarse touch pathways, which is going to be carried on either the anterolateral system, or sometimes some people use spinothalamic tract and anterolateral system synonymously, but they really aren't synonymous. The anterolateral system contains both the fast pain and the slow pain pathways all collectively as a group. The spinothalamic tract should be only used when you're referring to just the fast pain pathways, the fast localized pain. But I put it all together, anterolateral system / spinothalamic tract, that's going to be collectively your fast and slow pain from the body. And then we have a synonymous trigeminothalamic tract, which carries both fast and slow pain from the face and head. Okay, and we'll actually talk about a trigeminal limbic. You'll see there's a crazy way to describe more of the trigeminothalamic typically should be used to describe just the fast pain from the head, but there is a slow pain equivalent of that, which we'll mention briefly when we get to that point. All right, so we're going to start diving in. We're going to start with conscious. We're going to start with the dorsal column medial lemniscal system and the trigeminal tract. Talk about that first. Here's the very simplistic way of looking at all these pathways in one big kind of one diagram here. First of all, this last one's motor. We're not there yet, so you can just ignore motor. So if you just look at pain and temperature, if you want to get really just super basic, the pathway comes in. The little dotted line, that's the midline of your central nervous system. That's the midline, okay? It crosses. Where does it cross? It crosses wherever it actually comes in. So if it's coming in from the upper body, it's going to come in here. It's going to cross over. It's coming in from the lower body. So this is your spinal cord, and this you can kind of divide it into lumbar and cervical spine if you want. Then we have our crossing point here between this and the brainstem. Then it stays on this side and eventually goes to the thalamus, which then goes to the cerebral cortex. Okay? So the main point here is it comes in, it crosses, and it crosses over in the spinal cord, spinal thalamic pain and temperature pathway. And that's all they're showing there is the spinal thalamic fast pain that actually makes it to your cerebral cortex for conscious awareness. Here's our dorsal column medial lemniscal system, which is carrying proprioception, Stereognosis is just your ability to, like, say, if I put something in my hand, I can tell you that's, if I close my eyes, that's a pen in my hand, or that's a pencil, or that's a coin that you put in my hand. That's stereognosis, three-dimensionality that you can feel. That's part of proprioception that we have. This is conscious. You're aware of it, so it goes to the thalamus and cortex eventually. But you see, here it comes in on one side, it goes up in the spinal cord on the same side, and it crosses right here between the brainstem and spinal cord junction. It actually crosses in the low medulla there. That's what they're trying to represent, is that's where the crossing point happens. And then it ascends as the medial lemniscus once it crosses over, and then goes up to the thalamus, and then the cerebral cortex for conscious awareness. Here's light touch. This is crude light touch, and this is discriminative or fine light touch, okay? So light touch, you'll notice, is carried on both the spinothalamic and the dorsal columns, but they're different types of light touch. The type of light touch is just very crude, like, yeah, you touched my arm. That is carried also on the pain and temperature pathway. It's actually carried on this anterolateral spinothalamic tract system to give you some crude awareness of sensation of touch, okay? But to actually be able to pinpoint exactly where I touched you and get that more discriminative light touch, that's carried on the dorsal column medial lemniscal system. One of the reasons I point this out is because light touch is a crappy sensation to test to differentiate between dorsal column and medial lemniscal systems and the spinothalamic tract. If you have a patient who's had an injury to the spinal cord, this is where it would come to, you could have a person where they could have damage to this medial lemniscal dorsal column system, and if you tested their light touch on one side of their body, and you didn't, if you just said, can you feel me touch your arm? And they say, yeah. And you say, oh, seems normal to me. That could have been carried on the anterolateral system, even though the dorsal column was damaged. But you have to actually get very specific and say, exactly where did I touch you? And you want to apply the stimulus in a way that you're very selective about it so that you can discriminate between, are they just feeling this coarse light touch, or are they actually feeling discriminative light touch? That's why I don't use light touch very much, because I don't even have to want to worry about that. So I use vibration. Vibration is carried on the medial lemniscal system exclusively. It's not carried on this spinothalamic tract. And that's going to give me a little more discernment. And I also use pinprick is going to be only carried on the spine. So if I really want to discern between the dorsal column medial lemniscal system and the anterolateral system, those are the two ones going up the spinal cord that tell us about either conscious proprioception or pain and temperature. I'm going to do the pinprick test, and I'm going to do vibration. Those two modalities of sensation are distinct from each other and carried exclusively on those pathways, where light touch is carried on both pathways, but in a slightly different way. You just got to be really good at making sure you ask the right questions and apply it right to make sure you can discern between those, okay? And then lastly over here, here's the unconscious proprioceptive pathways. They're putting all these spinocerebellar tracts as one group, which is okay here. There's actually 4 separate ones, but if you want to group them, they all do the same thing. They come in on one side of the body, and they go to the cerebellum on the same side of the body. So they do not cross. These are the only pathways of sensation that don't cross. So the clinical significance here is if I have damage to this is looking at it, my right cerebellum, I'm going to have right coordination problems on the right side of my body, okay? So the damage to my cerebellum is going to elicit symptoms on the same side of my body, whereas if I have damage up in my cerebrum to some of the pathways of proprioception and pain, they all cross over. So I'm going to have loss of sensation on the opposite side of where the lesion is, okay? And we'll get into this when don't worry about all that now, but I'm just starting to start opening the doors to some of those clinical concepts. But we're going to reinforce all those again as we go through each of these pathways, okay? So let's go through conscious proprioception, discriminative touch pathways, which are collectively known as the dorsal column medial lemniscal system, okay? And it'll make sense why it's called that when we start going through the pathways here. So let's start with from the receptor and we'll go all the way up through the pathway. Okay, so starting at the receptor, typically you're getting information from just about every type of receptor out there. Okay, especially all the corpuscles and discs and peritracheal endings, which is just the hair follicle ones, peritracheal endings. Also muscle spindles, GTOs, and joint receptors. Also free nerve endings. Okay, so pretty much you get the dorsal column, medial meniscal system gets information from anything that can be act as a mechano type of receptor, which pretty much everything can be a mechanoreceptor. I mean, free nerve endings can act as a mechanoreceptor, and everything else is pretty much mechanoreceptors. So the types of modalities of sensation you're getting from this are things like pressure touch, how much pressure you're feeling at any given point, and that helps you give you awareness of the shape, texture, size of objects. It gives you information about kinesthesia, which is awareness of movement of the limbs. Kinesthesia is actually the awareness of actual movement. Proprioception is kind of this catch-all term that describes, it could be kinesthesia, which is the actual movement of the limbs, but some people refer to it as proprioception as just the static position sense, but it really isn't. Proprioception is kind of this more catch-all term for both kinesthesia, awareness of movement, and then this position sense, which is just more static position, where your body is in space at any given moment statically. Okay, and that's your spatial relationships of body parts to each other in a static type of position. So these two, kinesthesia and position sense, collectively are more like proprioception. Proprioception. Then we talked about the weight of an object, that perception of weight, that's carried on the dorsal column medial meniscal system. And then stereognosis, the appreciation of an object's three-dimensionality and the shape of that object and what that object is. That's typically done with your hands. You know, so you got to kind of have your hands to do stereognosis because you're manipulating the object, trying to feel it. So now we're going to, that information has come from our peripheral receptors. It's going to go up depending on the type of sensation, depending on which receptor it came from, it's going to be carried on a peripheral axon, anywhere from a 2, 1B, A beta, 1A, all those can carry information that's proprioception, you know, conscious proprioceptive information. Okay, so our first order neuron, the first neuron in this pathway, the cell bodies are going to always be in that dorsal root ganglion. Okay, so we're going to follow, starting from, let's look at lower body. Okay, so starting from the leg. So here's our lower body, right here. So let's say that is some type of a joint receptor, something like that, and it's carried on a type 2 nerve ending. You know, so this axon might be a type 2 nerve ending, but the cell body for it's going to be sitting right here. Here's the cell body, and it's in that dorsal root ganglion. Okay. This may be coming in through my L5 nerve root. This axon may be coming in through my L5 nerve root. When it comes in, it's going to come in, it's going to enter the spinal cord through what's called the medial division of the dorsal root. So this little area back here is the dorsal root. And it's going to enter the medial division of that dorsal root. And I'll show you a picture of what I mean by the medial division of that dorsal root. So it's going to come in the back door of the spinal cord. And it is going to come in and it's going to go immediately into what's called the dorsal columns. So this area back here, you have a dorsal column. The back part of your spinal cord, the white matter, are called the dorsal columns. Okay? And initially in the lumbar spine, you just have 2 dorsal columns because all you have is information coming from your left and right leg. When you get up into your cervical spine, you layer on another dorsal column on the outside of that for your upper body. So you have 4 dorsal columns when you get up into your cervical spine because you layer on some more axons on the outside. And that's actually why your cervical spine is bigger than even your lumbar spine. It gets a little bit bigger. We call that cervical enlargement because you're adding on information from your upper body. It has to get carried into that spinal cord once you're up in your cervical spine. So let's just focus on lower body though. So it comes in and it ascends in the posterior funiculus. This whole region here is called the posterior funiculus, which is synonymous with the dorsal columns. So the dorsal columns are what is called your posterior funiculus. Okay. That one dorsal column on one side here by itself is called the fasciculus gracilis. So the fasciculus gracilis is just the single dorsal column associated with the lumbar or lower body segments of the spinal cord. Does that make sense? So this little area is called the fasciculus gracilis. And you have another one on this side, fasciculus gracilis on this side. Together, these are called either the dorsal columns as a group or the posterior funiculus. Those are somewhat interchangeable terms. But we're going to go up on just one of those from one side of the body here. So this is coming from the left foot. It's going to go up the left fasciculus gracilis on that left side. And then here it is here. Here's the fasciculus gracilis right here. It's more medial. It stays more medial. This is actually the upper body layers on another column here called the fasciculus cuneatus. Okay, but we're not worried about that yet. So we're focusing on just the information coming from the lower body. So it makes sense that this is called the fasciculus gracilis because you have a gracilis muscle in your leg, right? So that's how I remember that dorsal column information coming in the dorsal column that goes up the back of the spinal cord from the lower body ascends in the dorsal column called the fasciculus gracilis. Okay? That's if it enters anywhere below T6. So any of the information coming from your body or leg from below T6, it'll go in and go into the fasciculus gracilis. Okay? If it enters anywhere above T6, it goes into the other dorsal column that has now been added on because now we're getting upper body information called the fasciculus cuneatus. So the fasciculus cuneatus and the fasciculus gracilis, once you get above T6, so you don't even have a fasciculus cuneatus below T6. Not till you get to T6 do you start to have a fasciculus cuneatus. Below that, all you have is a fasciculus gracilis. But now once you get above T6, you have both a fasciculus cuneatus and a fasciculus gracilis that are still just part of your dorsal columns as a group. Okay? So let's just stay with the leg right now. The first synapse is going to happen in an area called the nucleus gracilis or the nucleus cuneatus. Okay? So for the lower body, here's the lower body coming up. Here's the lower, so here's the cervical cord, lumbar cord, lower medulla. So in the lower medulla, this is a horizontal section through the lower medulla. You have some nuclei sitting in the back of that lower medulla. And the first one we're going to talk about, the more medial one, is going to be the nucleus gracilis. Because remember that dorsal column that's more medial is the fasciculus gracilis. And so that lumbar and lower body below T6 proprioceptive information is coming up that fasciculus gracilis. And then it's going to synapse with the second order neuron. The cell body for the second order neuron is located in that nucleus gracilis. So this is where your next cell body is going to be located. Is right in there. And it's actually showing, it's like a little bit of a, here's your axon coming up with its little axon terminals, and here's the next cell body located in the nucleus gracilis. As soon as that connection is made, the axon from the second order neuron crosses over midline. It actually dives a little anterior, but then crosses midline right there after it makes that synapse. It stays real close to midline, but it crosses midline in the lower medulla. So this is the crossing point for the conscious proprioceptive discriminative touch pathways. Once it crosses over, now it changes names. And the rest of the way up, it's called the medial lemniscus. So it was ascending up the fasciculus gracilis, made a connection at the nucleus gracilis, crossed over in the low medulla, and now because it crossed over and we're in the brainstem, it changes names, and now it's called the medial lemniscus the rest of the way up. And a lemniscus means ribbon-like, and it does kind of flatten out. Your dorsal columns are more, I don't know, roundish or, you know, triangular in nature. But once it gets, the medial lemniscus gets more flattened out, okay? And you'll see it here. This structure right here, this is the medial lemniscus. See how it's a little more of a flattened structure? And then here, it actually twists. Your medial lemniscus, as it comes up, this is your axons, are all carrying information. It twists as it goes up through the brainstem. It goes from more of an orientation of medial to anterior to posterior to more medial to lateral as it twists and goes up, okay? It kind of changes position. So you see here the medial lemniscus is more in an anterior-posterior arrangement, but here it twisted and now it's more in this medial to lateral arrangement. And then it starts to twist back again. Here, when you get up in the midbrain, it's not that critical to know. I'm just saying that's why it looks different as it goes up. It's this twisting like a ribbon. That's why it's the medial lemniscus. It's like a ribbon-like structure. And it twists again in the midbrain to be more anterior to posterior. And then finally, so this is the second order axons. You know, the cell body was down in the nucleus gracilis here, crossed over, goes up in the medial lemniscus, and then it makes a connection with the third order neuron in the thalamus. And it's a specific area in the thalamus called the VPL, the ventral posterior lateral part of the thalamus. Don't worry about that now, just know VPL, okay? Once it's made its connection in the thalamus, the third order neuron carries information from the thalamus to the appropriate location in the cortex. And in this case, if it's a lower body structure, a foot, remember the lower body kind of wraps over the top of the cortex onto that medial surface? That would be the sensory homunculus, the lower body representation would go right through here. And this little area of white matter right here, that's called the internal capsule. It passes through, that's called the internal capsule. So the second order neurons are within the nucleus gracilis or cuneatus. It desiccates, which means crosses, in what's called the lemniscal decussation. So this area right here, this crossing point, because on this side you have the other ones crossing from here, from the other side of your body. So this crossing point is called a decussation. That's called the lemniscal decussation, is where that crossing point occurs. And then once it ascends as the medial lemniscus on either side, goes up to the thalamus, makes its next connection with the third order neuron in the VPL, the ventral posterior lateral part of the thalamus, and then goes up to the cortex, which is the third order neuron. So the cell bodies for the third order neurons are in the VPL, and then it ascends through this posterior limb of the internal capsule. That's this and when we get to cross sections through the cerebrum, you'll see what this posterior limb of the internal capsule. It's just white matter. It's axons. Remember, a capsule is a white matter axons, groups of axons. Okay. And in that internal capsule, you have both sensory axons, but also some motor axons. This just happens to be the sensory axons are carrying that. And then it terminates in the postcentral gyrus, the corresponding homunculus on the postcentral gyrus of the cortex. And that's where we're going to make that conscious awareness of like, hey, somebody touched me right there because I'm feeling it in that little spot and those cells in my cortex that give me that somatotopic appreciation for my representation of my body. That's for the lower body. Now the upper body is easy because all you got to remember instead of gracilis, it's cuneatus. Everything else is the same. It's just that in the upper body, it comes in, if it's above T6, Any of the information coming into nerve roots above T6 are going to come in and they're going to enter into the dorsal columns, but more laterally in the fasciculus cuneatus instead of the fasciculus gracilis. And then it's going to ascend and it's going to synapse with the second order neuron where the nucleus is lying in the nucleus cuneatus, which is just a little lateral to the fasciculus cuneatus. It's going to cross right over just with the lower body stuff too in the lemniscal decussation in the lower medulla, and then it's going to join up with the lower body stuff, and they're all going to go up together in this medial lemniscus, this ribbon thing that's going to twist up with those axons twisting as it goes through the brainstem, and then they're both going to go up to the VPL, and then they're both going to go then through the internal capsule into their respective areas. So the upper body is going to go out. Here's the arm. The arm's going to go out here. So this would be, and then face is more out here, okay? This first pathway is the hardest because you're just learning like where are all these cross sections at, what are the names, getting your orientation. After this, they come easy. So the first one is the one that we really have to kind of walk you through every little part of this and just make sure you feel comfortable with what's going on. Any questions on dorsal column, medial lemniscal system, upper and lower body, conscious proprioception? We'll get to face here in a second. Yeah, let it settle, let it sink, and then the only thing I want you to appreciate this is like kind of a weird diagram because now these are the same similar cross sections. Here's lumbar, cervical, low medulla, mid medulla, pons, midbrain, but this is anterior and this is posterior, okay? But the thing I want you to show here is this, the nice part about this picture is it shows the information. This is the dorsal column medial lemniscal system. The lower body stuff is in blue, upper body is in red. So it's kind of nice just to see the blue and red, how those are arranged and layered in, those axons from the upper and lower body at different points in that dorsal column medial lemniscal system. And then even when it gets up, this is your thalamus, this is the VPL. So this more lateral part of the VPL tends to process the lower body, and this is a little more upper body, more medial in that VPL nucleus. That whole area is called the VPL. And then you can see up in the cortex where it's going to the different regions representing the upper body and lower body. But you can see here, that's a little bit hard because it's a little small. But you can see once you get into the dorsal columns here, initially your dorsal column, medial lemniscus, once you get into the medial lemniscus, originally when those axons come in there, your upper body information is more posterior and your lower body is more anterior. But then as you swing up into the pons, it starts to twist. It's that, right here it's that more anterior to posterior arrangement. And then it twists, as it ascends, it twists like this. And now lower body is more lateral and upper body is more medial. And then it continues to twist further as it goes into the midbrain. So now we got more of a posterior arrangement where the lower body proprioception is and a more anterior where the upper body. This starts to play some role when we start talking about lesions in the brainstem and different lesions and how they might affect more upper versus lower body and also in the spinal cord. So don't have to feel like you know that now. I'm just trying to give you an appreciation that this somatotopic arrangement of even how the axons are layered in these columns maintains some somatotopic arrangement. They don't all get totally mixed up together. There's still some separation between these so that if you get damage in one part of your brainstem, you might just affect lower body proprioception versus upper body, depending on the extent of the lesion, where the lesion is, and that kind of stuff. What? What's wrong? Oh, crap. Does that just happen and it keeps going? You can't figure out a way to... Has anybody figured it out the way to get it turned off or no?
You did last.
Did I? I think I just pushed on buttons till it stopped. Hang on a sec. Let me see. Oh, that didn't work. I stopped it, but I shut down the whole screen and everything. Let me see if that comes back up. Take a second to boot up here. You guys need a second to process all that dorsal column, medial meniscal stuff anyway. Probably a good time for a break anyway. You guys are, yeah, let's take a break. Come back in about 7 minutes. Yeah, sure.
Did you say the trigeminal pathway terminates with the posterior iris as well? Or is that a different?
It does, but we haven't got to the trigeminal pathway yet. That's next. Yeah, we haven't got there yet. But it does also terminate the postcentral. Unfortunately. I wanted to point out on these pictures here. So the first one in your packet should be the dorsal column medial lemniscal system. So it says on the bottom what the modality of it just says discriminative touch and proprioception. So you could across the top if you want or whatever write medial lemniscal dorsal columns here. So that's this picture, and this gives you some of the nice cross sections, and just make sure you look for your reference on the side here where you're at in the nervous system. These are the key cross-sectional areas you're going to see with every one of these pathways pretty much. And so you can, if you wanted to go in and color blue and red or however you want to show for upper versus lower body on here, you could probably do that on this particular diagram. And then the second diagram is spinal thalamic tract. Just the fast pain spinal thalamic tract that goes to your cortex for conscious fast pain. That's the other pathway that's shown on there. So sometimes if you might want to, like as I'm going through that, I should have told you that ahead of time, is have this on your desk. Sometimes it's a little easier to see, a little more detail than what you can see on these slides from your book and what I'm trying to show you up here. So. Okay, what did I want to so here is, you know, your dorsal root we talked about. So that first order neuron, that axon, comes in the dorsal root in the back part of your spinal cord. But there's also the dorsal root ganglion. This whole thing, all these blue axons, oh, sorry, it's not showing up. Why not? It's not showing up on that one for some reason. That sucks.
We have the blue part, but we're just missing everything else around the blue part.
You got the blue part, yeah. Why? Let's see if I do source here. Source search. Come on, baby. Find it. There we go. I still got it. Figure this stuff out. All right, so if I draw a circle around all of these, this is our dorsal root. Okay, so this is the dorsal root. So that's a big dorsal root, and there's axons in that dorsal root that are bringing in information from all types of sensory experiences. Pain, temperature, proprioception. The ones that come in the medial division of the dorsal root are the ones that are more associated with proprioceptive. So remember I said that first order neuron, it comes in the medial division of the dorsal root. That's these guys, and they're more medial. Medial is this way, right? So they're more medial. This is more lateral. So the lateral group is pain and temperature. Axons that come in the medial division are proprioceptive, dorsal column, medial lemniscal, and spinocerebellar type information. That comes in the medial division because The medial division goes directly into the dorsal column here and then goes up. Here's the cell bodies. These cell bodies collectively form the dorsal root ganglion. But the ones in the lateral group, which we're going to get to, spinal thalamic tract and anterolateral system, they go right into the gray matter here, and they make a synapse pretty quickly in the spinal cord right away, where the dorsal column and the medial division here, they come in and go up the back of the spinal cord and don't make an immediate connection. They go all the way up to the medulla before they make their first synapse. So that's what I mean by the medial division of the dorsal root versus the lateral division of the dorsal root, which we'll get to when we talk about spinal thalamic tract. This is just different cross sections through the spinal cord. This is the spinal cord up here, up on this upper right-hand side. That's a stained section through the cervical spines. That's a cervical, it's about a C6, C7 probably, spinal cord section that is stained. So that actually the white matter tends to be a little darker and the gray matter tends to be lighter. So the white matter is the actual axons. And here's the dorsal columns. And let me do something a little different color here. So this is actually the fasciculus gracilis. That's the more medial dorsal column up in the cervical spine. It's carrying lower body proprioceptive information. Then this right here is the fasciculus gracilis. And it's even larger proportionally because it's carrying a lot. Your upper body has actually more proprioceptive information, much richer, more receptive fields, more proprioceptive information coming from your upper body than your lower body, and it's layered on to the outside there, and that's why your, spinal cord gets kind of more, larger medial lateral, starts to kind of get a little more oval in nature when you get up here in the cervical spine. Okay. This is fasciculus cuneatus, and this is fasciculus gracilis. Okay. That's the cervical spine that you're seeing. That this section, this picture on your lower left, that is a cross section through the medulla, the low medulla. It's this cross section right here, low medulla, at that's the decussation. Okay, the lemniscal decussation is where this is at, and I'll show you that on here. So let me just point out a couple things here. This structure right here, the lighter stuff is actually gray matter or cell bodies, the way this is stained. This is the nucleus cuneatus. It's more lateral. This is the upper body. This is the nucleus gracilis right here. Actually, that's the nucleus gracilis. And that's the nucleus cuneatus. And what happens is, so you've got your dorsal columns coming up from the spinal cord, and I'm going to make a little dotted because this is coming up from lower below this. It comes up, and see this area here, this darker area, that's actually the white matter. Then this area right around here, this is the white matter. That's actually the fasciculus, the remnants of the fasciculus cuneatus, and the coming up, and the axons are going to come and make a synapse here with the cell body for the second order neuron. This is the dorsal column, medial meniscal system. The same thing here, you have axons coming up and making a connection here so this is the nucleus cuneatus and nucleus gracilis, so upper and lower body information. Those axons go and they cross, and this is where your medial lemniscus starts to get formed. And so this axon comes and crosses over, and then once it enters into this location, and now it becomes, and it goes up as the medial lemniscus. And then goes up and starts twisting as it goes up through the brainstem, and eventually to the ventroposterolateral nucleus of the thalamus, and eventually to the cerebral cortex. Okay? But remember, you've got the exact same thing happening on the other side. You got the same thing happening, and you have these same cell bodies with their connections here happening, and they're crossing over to get into the medial lemniscus and form the medial lemniscus on this side. And so where this crossing is happening, this point right there is the lemniscal decussation, where left and right sides are crossing over to the other side. Make sense? This is up in the midbrain. So this next picture is the midbrain. And this is your medial lemniscus. Now, again, more of an anterior-posterior arrangement. Down in the pons, it's more of a medial-lateral arrangement. It's twisted back to a more anterior-posterior arrangement. This region here is going to be more cervical and upper body, and this area back here is going to be more lumbar. Cervical, lumbar. Okay, so that's just how it's oriented in that way. So if you had a lesion out here, you might just involve lower body proprioception. That would be unusual. You could have, like somebody with multiple sclerosis could have a very small lesion that just impacts that little spot and causes lower body proprioceptive loss because of a small sclerotic MS lesion in the brainstem. So that's why MS is really tricky, because you can have such small lesions anywhere in the central nervous system. So it's hard to isolate where the lesion is sometimes, because you could have a small lesion somewhere in the spinal cord that could cause the same thing. You have to do an MRI, though, to be able to figure out. Especially with MS, it's a little harder. Strokes, a vascular territory has been involved, so you usually get a constellation of symptoms that are multiple types of symptoms that are associated with the vascular distribution when we get to vascular lesions and types of symptoms. So we'll start teaching you how to differentially diagnose based on key critical features that help you to isolate or get a pretty good guess of where a lesion might be located without any kind of MRI. You could get pretty close to most lesion areas. Not exact, but pretty close. The only thing I wanted to point out again here, this is looking at the back of a brainstem, the surface of it, right? This right here and this right here, there's little lines you can see there. This is where our fasciculus gracilis is, just deep to that. That's not the fasciculus gracilis looking at the back of the brainstem, just the back of the brainstem, but just deep to that is the fasciculus gracilis. That's the axons that make up the fasciculus gracilis are deep in there, okay? And then we can there's another little bit of a line here that you can kind of define out here on the back of a brainstem. Then the more lateral column there, that's the fasciculus cuneatus. That's just deep underneath there is the fasciculus cuneatus. And then these bumps, you have a bump here, a bump here, a bump there, and a bump there. Those are your gracile tubercles, are the two medial ones, are both gracile tubercles. The two lateral ones are cuneate tubercles. And if you go deep beneath those tubercles, what's there is the nucleus gracilis, just underneath the gracile tubercles, and the nucleus cuneatus, just underneath the cuneate tubercles. So, but from the outside, they're called tubercles. But in the cross-section, they're called a nucleus, because you're looking at the actual cell bodies in the nucleus. But there's little bumps back there that are called the gracile and cuneate tubercles. And that's why, because just deep to those is the actual nuclei. So if you wanted to use this little diagram to draw like your first order, second order, third order neurons and all that stuff, depending on so let's just say this is a foot. I need to take some art classes. I get them free here as a faculty. I can just go down the hall and learn to draw some art classes. The person that taught me neuroscience, he was amazing. He actually still teaches at Andrews University up Michigan. He's like a gifted artist, and he'd just go up here and no PowerPoint, just colored pens and just draw this stuff just so elegantly. It made me so jealous. So, but thank God I had this technology came along when I started teaching, or else I would have been totally lost. So here's our receptor out here. Okay, whatever it might be, a Meissner corpuscle, Pacinian, whatever, joint receptor, it's going to send a signal into this side of the lumbar spine, okay? So this is lumbar. So we see lumbar versus cervical here. We divide the spinal cord into lumbar and cervical. Our midline is that dotted line between left and right. Our cell body is out here in the DRG, right? It's going to go in the medial division of the dorsal root, and it's going to ascend in the dorsal column, and we would call that the fasciculus gracilis, right? And it's going to stay in the fasciculus gracilis all the way up to the spinal cord if it's coming from the lower body. It's going to go into the low medulla, and it's going to synapse with the second order neuron. Maybe we'll make this a different color. Let's do this. Let's turn that to blue. It's going to synapse with the second order neuron, and that's going to happen in the nucleus gracilis, right? This is just lower body right now. It's going to immediately cross over, and that is the, lemniscal decussation, LD, lemniscal decussation, where it crosses over. And then it's going to ascend all the way up in the thalamus, through the brainstem. This entire way, it's called the medial lemniscus. So in the brainstem, it's called the medial lemniscus. This looks like the eyes of this thing. It's not the eyes, it's the thalamus. And it's divided into a lateral and a medial division. We're going to the lateral. We're going to the VPL, the ventroposterolateral part. So that's going to go up here, connect here, and we'll do another color. We'll do green. And the third order neuron's right here, cell body for it. And because this is a leg or a foot, it's going to go over to this medial part of the cortex. So this cortex is, so we're going to go to that medial aspect of the cortex. And then this little area right through here that's actually traversing through is called the internal capsule. Is the internal capsule. So if you can draw that out like that just from memory and just identify those key elements, that's all you really need to know to be able to do well on my exams for this kind of stuff, okay? So just being able to identify those key elements and kind of draw that out. Do one for upper and lower body, yeah. No, it's still the VPL. All the body stuff that goes to the cortex, whether it's pain and temperature or proprioception, is going to go to the VPL. And I think of VPL leg, so that means body. VPM, this is called the VPM. That's all face. And I think of M as like mastication or masseter, and that's how I remember that VPM is associated with information coming from the face that's going to make it to your conscious awareness. So, good question.
So if you were to draw like an upper arm,
Yep.
showing an upper arm, the only thing that would change would be fasciculus cuneatus.
Correct. The only thing that would change would be fasciculus cuneatus and nucleus cuneatus. The rest would stay the same. So that's where you start to when you start to appreciate these, you don't have to memorize every single one individually. You start to look for commonalities. Once you get from those two different columns, you get to everything's in the medial lemniscus at that point. It's good to be aware that they still stay somewhat distinct in that medial lemniscus. There's still some somatotopic arrangement within that, but don't get overwhelmed by, even though I show it twisting, but don't get too concerned about that. But know that there is some somatotopic arrangement that is maintained within that medial lemniscus system. Don't get too hung up on this pathway. Just know that there is a corresponding part for our face that tells us about conscious proprioception of our face, okay? And that is called, there's not a great name for it. I've looked for a specific name, the trigeminal lemniscal system or something like that. And it's really just the trigeminal, nobody's really identified it. Just call it the trigeminal pathway that's associated with proprioception from the face, okay? It has 3 orders of neurons because it does, this is conscious, it goes to the cortex. So the cell bodies for this first order neuron are in the trigeminal ganglion, trigeminal nerve ganglion, which is this big guy right here. Trigeminal nerve is a big nerve. Our face is richly innervated with pain receptors and proprioceptors and everything. So there's lots of cell bodies in here, but this is for conscious proprioception from the face coming in. So this is left side of the face coming in the left side of our brainstem. It goes in and makes a connection pretty quickly at the level of the pons. This is the pons. It's coming in at the pons. We do a whole thing on cranial nerves, and we'll go through these again. We get to cranial nerves. This is just one of the cranial nerves that's bringing the trigeminal nerve is a cranial nerve that's bringing in some proprioception from your face. It makes the second order neuron. Cell bodies are located in what's called that trigeminal main sensory nucleus. So main sensory nucleus, that's that one. You actually have 3 separate nuclei associated with your cranial nerve. You have a separate one that's specific to pain and temperature. There you have a separate nuclei for proprioception called the main sensory nucleus. Once it makes its connection, it immediately crosses over in midline. And then it actually ascends as the trigeminal lemniscus as part of so the medial lemniscus is out here. It tacks on to the medial lemniscus as a little separate part as the trigeminal lemniscus. So you have a little part, once it crosses over, it joins up and tacks on to where the medial lemniscus is, but it's its own little separate bundle of axons that are associated with the face. So you have some bundle of axons for the lower body, upper body, and the face, but they're all right next to each other, ascending as this lemniscus. You have a trigeminal lemniscus and a medial lemniscus. The medial lemniscus is the body, upper and lower body. The trigeminal lemniscus is the face, part that's tacked right on, right next to it. So even up here, it's in the same location. This is all medial lemniscus, and the trigeminal lemniscus is just the little tacked on area, most anterior in this case, but don't worry about that. Just know that it joins up with the medial lemniscus, but it's still called the trigeminal lemniscus. Okay, it's its own lemniscus. Ascends in the trigeminal lemniscus and ends in the VPM. So it's the more medial nucleus of the thalamus, not the VPL. It's the VPM is where it makes its connection with the third order neuron, where the cell body for that is in the VPM, and then that goes out here to this is where your facial representation is more lateral and lower on the sensory homunculus. Okay, it though still passes through the internal capsule with the other parts of your body and goes to the cortex. Got it? So just trigeminal version. It is still the posterior limb of the internal capsule. Lots of stuff goes through the posterior limb of the internal capsule. Sensory and motor is traversing through the posterior limb of the internal capsule. So kind of a similar thing as the body, but just the trigeminal. Trigeminal nucleus, main sensory trigeminal nucleus, a trigeminal lemniscus versus the medial lemniscus, and then it goes to the VPM instead of the VPL in the thalamus before it goes to the cortex. But you'll notice, just as with the body, the left side of the face is going to the right side because it crosses. It crosses over here, right there, right at the level of the pons. And I don't even know, I'm trying to think if they do call this something. That crossing point is called like the trigeminal lemniscal decussation or something like that, but don't worry about that. But it's because you got crossing from this is the main sensory nucleus coming in, you got information coming from the other side of the face, and it crosses over too. So there's a crossing point for the trigeminal information proprioception from the face. This is just showing you, only thing I want to show you here, this is a cranial nerve. So you have the trigeminal nerve has both some motor components and sensory components. The sensory component that we're talking about here is The proprioception goes to this. This is where the nucleus, the main sensory nucleus, is located within the pons. But there's also a mesencephalic nucleus, and there's also a spinal nucleus, which we'll show when we get to pain and temperature about the spinal nucleus. It's processing pain and temperature information as it comes in. But we just talked about all we talked about is this main sensory nucleus that's located in the pons, bringing in proprioceptive information from the face, jaw, head, neck kind of region. Okay. Woohoo! Yeah.
So were those modalities the
Same modalities that you get from same modalities that you get, and as we were talking, I was talking to Christy. So on that table, when you talk about dorsal columns and trigeminal pathways for the actual peripheral nerve classification, it's going to be like everything except for C and A delta fibers. It's going to be everything but C and A delta. So it's going to be 1As, 2s, 1Bs, A betas. All those carry proprioceptive information that can be consciously aware of. So, all right. That was conscious proprioception. Stuff we're aware of, stuff we're consciously, I know where my body is in space, that I can feel. This is now next is unconscious proprioception. You have no conscious awareness of this information, this sensory experience that's happening. It's going to your cerebellum. So it makes sense. It's called spinocerebellar tracts. That tract, the information comes in, and it starts in your spinal cord, and then it stops in the cerebellum, spinocerebellar pathways. Okay. We have 4 spinocerebellar pathways. Okay. Many books will just refer to the first 2. The first 2 are called high fidelity pathways. They are bringing in the information from the actual receptors in your muscles, ligaments, joints, and sending that to your cerebellum. Okay? You have one of those that's associated with the lower extremities, called the posterior spinocerebellar pathway. And then you have one for the upper extremity called the cuneocerebellar pathway. And remember, we just learned about the fasciculus cuneatus and the nucleus. So cuneo tends to be associated with upper body. So that's how I remember the cuneocerebellar pathway is upper body. Posterior spinocerebellar, and that's got to be lower body for this. These are the high fidelity. These are the ones that are actually bringing in information from the muscle spindle fibers, from the joint receptors, from your ligaments, from your tendons, all that are going to your cerebellum. They're telling what's happening in the periphery, what is actually happening with your limbs and muscles and joints in the periphery. Okay. You also have 2 what's called internal feedback pathways. These are spinocerebellar pathways that don't have any direct connection with the actual receptors out in the periphery. They actually start in your spinal cord. They actually sense what's happening at the level of the individual levels of the spinal cord, and they're actually sensing signals that are coming down. So when you send a motor signal down to tell your muscles what to do, a copy of that message goes to the anterior horn of your spinal cord, because right before you send the signal out to the muscle, you're delivering that signal to that anterior horn cell to tell the muscle what to do. But what you have is you actually have a spinocerebellar internal feedback little pathway, sensory little neuron that is monitoring the actual signal that got sent to the motor fiber right at the level of the spinal cord. And it's monitoring the interneurons in that area to tell us about the state of excitability and activity happening at the actual level of the individual spinal levels. And it's monitoring a combination of both the motor signal that came down and the immediate proprioceptive information that's coming back in at that level. And then it processes this information and sends it up to the cerebellum. So it's kind of like, sensing both the external environment indirectly, but it's monitoring the internal state of the nervous system, both motor and sensory, right at the level of every level of the spinal cord to help monitor information, to send it back to the cerebellum so the cerebellum can process it. And if there's a mismatch between the signals you're expecting to send to the actual motor system, and if there's a mismatch between what you're expecting your body to do and what's actually happening in the real world, there's a mismatch and you're not coordinated, or a box you're about to lift is heavier than you thought it was, it monitors that and sends a signal back to the cerebellum. The cerebellum sends a signal back up to the cortex, so the next signal comes down and tries to correct for that. If the box is a little heavier than you thought it would be, the next signal is going to come down to strengthen up the next signal to those muscles. Okay, so the internal ones are sensing the internal activity at every spinal cord level and sending that to the cerebellum. And so you have the external high fidelity ones that are bringing in the peripheral information, but then you've got these guys that are monitoring actual very sophisticated activity of interneurons at each spinal cord level. I don't know if that's the best way to explain it, but it's the only way I know how. So that's called the anterior spinocerebellar tract. So these two guys are kind of paired, the anterior and posterior. They're both lower extremity. Posterior is the high fidelity pathway, getting in information from the peripheral receptors. The anterior is what's happening, monitoring lower body information at the actual in the spinal cord itself, at the level of the anterior horn area. It's actually that junction between the anterior and posterior horns. That's kind of like where your sensory and motor areas are close to each other. So it's monitoring the interneurons that are happening there. Then we have a rostrospinocerebellar tract. Rostro towards the nose, so you think upper body. So that's the internal feedback loop for the upper extremities, is the rostrospinocerebellar pathway. So let's start going through these spinocerebellar pathways. Posterior spinocerebellar pathway, receptors, muscle spindles, GTOs, joint receptors. That's your primary. You do get some from your surface sensors like Merkel's disc and Meissner's, but not very much. The most of it is from these muscles, tendons, and joints, okay, is where you get most of the information. This is high fidelity peripheral receptors bringing in information that's going to go to your cerebellum. It's sensing movement of the lower extremities and what position or posture your lower body and lower trunk is in, okay? It's unconscious awareness of that, okay? So here it is, posterior spinocerebellar. It is not making it to your cortex, so it's only going to have 2 orders of neurons. That makes it nice. You don't have to worry about remembering 2 orders of neurons. It's only 2 neurons in the pathway instead of 3, because it's stopping before it gets to the cortex. So here it is. This is showing you a nice little, I guess that's supposed to be a muscle spindle, okay, in the quad. And your quad is kind of innervated like L2, 3, 4, it's kind of the nerve roots. So anyway, so we're assuming this is now an axon bringing in, this is probably a really fast like 1A axon, right? Here's the cell body for it in the dorsal root ganglion. All of our sensory stuff, no matter what pathway, if it's coming from the periphery, the first order cell body is going to be the dorsal root ganglion. It comes in and makes its initial synapse in the dorsal horn, in the gray matter of the lumbar spine here, okay? And it makes its first connection in a particular region of the dorsal horn. It's a specialized region called the nucleus dorsalis, also known as Clark's nucleus. So if you hear nucleus dorsalis or Clark's nucleus, that is this specialized region right here of the lumbar spine, okay, of the gray matter. That's what's called, it's called, because there's a group of cell bodies there associated with these posterior spinocerebellar pathways that collectively are called the nucleus dorsalis or Clark's nucleus, okay. That nucleus dorsalis is only in the region from T1 to L3. So the significance there is if I had some proprioceptive information that came in from my foot, like down at L5 or S1, it would actually come in and it would go into the dorsal column and go up the fasciculus gracilis briefly until it got to the level of L3 before it made its connection. Does that make sense? It would actually ascend up the dorsal column first, but don't worry, you don't have to memorize that, but people always ask, well, if this nucleus dorsalis Clark's nucleus, this region right here, is only from T1 to L3. What happens if you come in from a nerve root below L3? Well, it just goes up the dorsal column until it gets to L3, L4, L3, L2, and then it makes its connection with Clark's nucleus and does the same thing as everything else does on the way up. And so what happens there, once it makes its connection, the axons of the second order neuron from nucleus dorsalis swing laterally into just this little region right here in the spinal cord called the posterior spinocerebellar tract or pathway. Posterior spinocerebellar tract, right out here. And then it just maintains that same as it goes up to the cervical spine. And it actually kind of sits very similarly out here in just this region of the low medulla, out posterior lateral. Okay, it's just called the posterior spinocerebellar pathway, and we'll show you where that is in some cross sections later. But then it goes into the cerebellum through the inferior cerebellar peduncle. Remember those, like we had those peduncles that connected the cerebellum to the back of the brainstem? There's an inferior cerebellar peduncle, a superior, and a middle cerebellar peduncle. These guys go in the underside. They go under the inferior cerebellar peduncle, coming up from lower. They're coming up from the spinal cord, so they go mostly into the inferior cerebellar peduncle. And they go and dump into the cerebellum on the same side. So it came in on the left side of the body. It's on the left side of the cerebellum. There was no crossing that occurred here. They stayed on the same side. Does that make sense? So that is the posterior spinocerebellar pathway. Lower body, high fidelity, coming from actual muscle spindles, okay, and proprioceptors and joint receptors. I'm just showing you, this is a cross-section through a spinal cord. You can divide the spinal cord into what's called these cellular archetypes, or different types of cells that have a little different characteristics to them, and there's a way we can divide them into various laminas called Rexid's laminas. Rexid's laminas, and there's 10 of those. And so when we talk about some of the connections when either motor pathways or sensory pathways come into the spinal cord, they may make connections within certain laminas as their first stop for where some of the cell bodies are located. Or there's also on this side, we can overlap. So we still have the laminas here, but we also have these other regions that sometimes that cross multiple laminas that also have some distinct cell types. And this one right here, actually, this is generally where Clark's nucleus, or the nucleus dorsalis, this is where the cell bodies sit for the second order neurons in the posterior spinocerebellar pathway, are here in the gray matter that actually tends to kind of cross between area lamina 7 and 6 and 7. It kind of sits in here between 6 and 7. So anyway, you'll see more about this when we get to cross sections of the spinal cord. So we're just starting to introduce this to you. So that's high fidelity lower body. Now we're doing high fidelity upper body. Cuneocerebellar, cuneate, cuneo, upper body, goes to the cerebellum. Same thing as receptors, right? Same types of receptors that we use for the posterior spinocerebellar, same types of modalities and postures, but upper body positioning and proprioception. Unconscious. All right. So let's follow let's follow the pathway here. So muscle spindle in the bicep here, okay? That's coming in on a muscle spindle. That's going to be our, it's going to be typically a 1A or 2, some kind of a pretty fast axon type that's going to be bringing that information in. It's going to come in the cervical spine, and this is bicep, so it's probably maybe C5, C6, something like that that's coming in. And it's coming in the dorsal root. And it comes in the medial division of the dorsal root. Remember, all the proprioceptive stuff, including unconscious, comes in the medial division of the dorsal root. Cell bodies out here in the dorsal root ganglion, just like all the other sensory axons are. It comes in, and it comes in the spinal cord, and it ascends in the fasciculus cuneatus. It uses the fasciculus cuneatus, okay? And it ascends up into the lower medulla as the fasciculus cuneatus to then make its connection with the second order neuron, which is actually in a distinct nucleus sitting a little lateral to the, here's the nucleus cuneatus, here's the nucleus gracilis. There's another nucleus that sits a little more lateral called the lateral cuneate nucleus, right? So this was the nucleus cuneatus, and this is the lateral cuneate nucleus. Just a little more lateral than the regular cuneate nucleus. And that's where this lateral cuneate nucleus is analogous to Clark's nucleus in the lumbar and thoracic spinal cord. But it just happens to be in the medulla. Because when you come in the cervical spine, there's not a lot of, you're going to be in the medulla pretty quickly, and it just goes up to the medulla, and then it makes its first synapse in this lateral cuneate nucleus that is similar to the region in the spinal cord for the lumbar spine of the Clark's nucleus or nucleus dorsalis. So then the second order neuron starts there. It goes in through the medulla as the cuneo-cerebellar tract. So once it leaves this, it's called the cuneo-cerebellar tract, and actually it's really hard to define and see in cross sections. And actually, when you look at cross sections, they rarely ever show you that pathway. And it ends pretty quick because it goes the medulla, then it goes through that inferior cerebellar peduncle, through the ICP, inferior cerebellar peduncle, to the same side of the cerebellum, just like the posterior spinocerebellar pathway did. It goes in through this inferior cerebellar peduncle. Superior is up here. This big one is the middle. It goes mainly in through the inferior cerebellar peduncle to dump into the cerebellum, to deliver its information to the cerebellum. Okay? And it's all on the same side, ipsilateral. It's an ipsilateral pathway. If I say something is an ipsilateral pathway, it means it starts on one side and ends on the same side. You'll see in a minute here one of the internal feedback, well, tomorrow, one of the internal feedback pathways, it crosses over, but then it recrosses as it gets up towards the top. So it's still ipsilateral, but it crosses twice, so it ends up back on the same side. So that's still an ipsilateral pathway, even though it crossed twice. It's only if it starts on one side and ends on the opposite. So the conscious proprioception, dorsal column, medial lemniscal system, starts on the right side of the body, ends on the left side of the brain. That is a contralateral pathway. All of your spinocerebellar pathways are ipsilateral pathways. Let's try to get through these real quick, and then we don't have to worry about them tomorrow. This next two pathways are the internal feedback loops. Don't need to know as much detail about them. These are the ones that they're not bringing information from the outside. They're monitoring interneuron activity at each level in the spinal cord, okay? The anterior spinocerebellar is for lower body. It's monitoring the interneuron activity in the spinal cord in the lumbar, sacral, thoracic, lower thoracic segments, okay? So it's got a starting point there. There's no receptors associated with it. Don't worry about that. Here it is, anterior spinocerebellar pathway. So the cell bodies start in the gray matter of lamina number 7. Remember I mentioned those laminas, those different laminas? Lamina number 7 that's this guy right here. This is lamina number 7. And those internal feedback loop cell bodies are sitting in here. They're perfectly positioned between, this is all motor stuff here, this is all sensory. They are in a perfect position to monitor interneurons that interact with both sensory information coming into the spinal cord and motor information going out. They're right on the ground, right at the spot that they need to be to say, this is what's actually happening right here at the spinal cord level. And they can send signals back to the cerebellum to say, is there a mismatch between the motor signals that are being sent out and the sensory information coming back in from a specific joint or movement to say, hey, you better turn up motor activity or turn it down or adjust the level of output so that you make it smooth it out, make it look more coordinated. Okay, so that's what they're monitoring these interneurons and signals right here and sending that up to the cerebellum. It's just another added piece of information from the cerebellum that gets both peripheral information and internal information, because that's why your cerebellum is so, you know, you know, got all those wrinkles and furrows, because there's so much processing going. It's receiving so much sensory information from both the external environment and your internal environment to make comparisons, to try to see if there's any mismatches happening between signals. So here's the anterior, is right here. The anterior is the lower body internal feedback loop. Here's the cell body sitting in lamina number 7 here, between the sensory and the motor aspects of the gray matter. This is very interesting. So what it does is the cell body, it crosses immediately called the anterior white commissure. There's a little bit of white matter right here called the AWC, or the anterior white commissure. It crosses over, the axons go over here, and they end up in this little area on the outside of the spinal cord called the anterior spinocerebellar tract. It's a little more anterior. The posterior spinocerebellar tract is back here. Here's the anterior. Anterior goes up, stays in this general vicinity as the anterior spinocerebellar tract all the way through the medulla. See, it's crossed over, but then when it gets up to the cerebellum, it actually goes in through the superior cerebellar peduncle. It actually goes up a little higher and goes in the superior cerebellar peduncle, but most of them cross back over. So most of them cross back over to the same side that they started on. Actually, I shouldn't circle that, because that's the posterior spinal cerebellum. Whoops. Come on. So it started on this side, on the left side, went up, crossed over to the right, and then once it got up here, it crossed back over to the left. I say mostly. There are still some fibers that actually stay on the same side, but we're going to assume it's still an ipsilateral pathway. I don't know what it's 80, 90% of the fibers cross back over, but a few go to the same side, or the other side of the cerebellum. Okay, but we are going to just assume that, just counting them crossing back over. So it crosses once down here in the lumbar spine, goes up, it crosses back over at the cerebellum. So that's why it's still an ipsilateral pathway. Okay? Rostrospinocerebellar pathway. This is the internal feedback loop for the upper body cervical spine. Okay? So here is its cell body. The starting point starts right here in that lamina number 7 of the cervical spine, and it ascends in the posterior medulla. That's all it says about it. Ascends in the posterior medulla. I'm assuming it's ascending as the rostrospinocerebellar tract, but you really cannot identify it on cross sections in a real cross section. They don't like point out this is the rostrospinocerebellar. They just know it goes up that back part of the medulla. Okay, and so you see it just kind of sitting back here. There's white matter back here, and it just sits in that kind of region right there, and then it enters in the ipsilateral, inferior and superior cerebellar peduncle. It tends to divide into both, some of it goes to the inferior, some of it goes up to the superior. That's not that clinically relevant to know. Just know that they all end up on the same side, starts on the same side, ipsilateral. The rostro doesn't do that little crazy crossing at the anterior white commissure like the anterior spinocerebellar. It just stays on the same side. Doesn't do that recross thing. Awesome. We did get through actually more than I was hoping we'd get through today. So that'll be good. So now you can just let it sit, let it fester. And we'll be able to take our time tomorrow, finishing up, talking about stuff, do a quiz tomorrow. We'll talk through the quiz. It's a bonus quiz. It's going to be on this stuff. And it'll be a little more of a quiz that's the level that you will see probably for the exam. So just to start getting you, it's all multiple choice, 5 questions, and we'll talk them through those questions afterwards. So, yeah, question.
So is it going to be over the stuff that we did today, or over?
It's over the stuff we did. It could be today and whatever readings you had. So it could also include the pain and temperature pathway. So it can be anything you were expected to read for today. Yeah. Got it? My research group, I do need to talk to you guys at some point. We need to talk about some things, but if you want to stop up real quick after the class here, but Another question here. Next quiz is on Friday, and I'll tell you tomorrow what that quiz is going to be over. Yep, I will tell you what that's going to be.